Hey, good morning, good morning, good morning, everyone. Thank you so much for joining us for a wonderful day here as the Caribbean College of Family Physicians Jamaica chapter welcomes you to the NCD and Nephrology webinar today, the 27th of April 2025. We thank you because today is Carnival in Jamaica as well. And we know that a lot of you could have been out there reveling, but you choose to revel with us. And so we have a wonderful program set up for you, and I'm going to hand you over to our capable moderator, the beautiful, the wonderful, the magical Dr. Arna Brown Morgan. Dr. Brown Morgan, over to you.
Oh, Sam, can I tell you that I absolutely love you? Thank you so much for your, your kind, lovely words. Enough to get any woman's head turned and in the right position to have a great day with everyone. Dear colleagues, it is my pleasure this morning or this afternoon now to welcome you all to another continuing medical education webinar held by the Caribbean College of Family Physicians, Jamaica chapter. It is a warm, should I say hot, sunny day in Jamaica, everything here right for the carnival. So we will have a carnival of learning and interaction and fun right here this afternoon. This conference today will focus on the impact of non-communicable diseases on renal function. And we cannot hear more than it is just a continuing need here in Jamaica where we have so many diabetics and hypertensives who are having chronic renal disease. We must top Caribbean figures for this. And so to this end, we will be welcoming two speakers from Duke University to share their experiences and knowledge in this area. So before I go ahead with that, I would like to ask Dr. Arlene Henry Dawkins, an executive member of the Caribbean College of Family Physicians, Jamaica, to lead us in prayer. Dr. Dawkins, welcome.
Good afternoon, everyone. May we honor the Lord God as we pray. Awesome, wonderful, loving Almighty God, we are so grateful for all your many blessings, mercies, and grace towards us. Therefore, Lord God, may we never lose sight of your faithfulness and love for us. And so we want to begin our meeting with thanksgiving and to welcome your holy presence among us. We are thankful for this opportunity for the Caribbean College of Family Physicians, Jamaica, to host another webinar where we can share and discuss various perspectives on this relevant topic of NCDs and nephrology. These diseases are serious life-altering conditions which are increasing and threaten the quality of life and health of our patients and their families. So, Lord God, we ask for your wisdom, insight, and guidance as we listen to the presentations and pray for focused and clear minds to retain all the information that will be imparted by our expert presenters. As we learn and engage in discussions, may we be empowered to manage effectively these NCDs before they progress to all the devastating complications. Help us to recognize that this requires teamwork from primary health care workers, specialists, families, caregivers, religious groups, and others involved in the patient's care. So, Lord God, we pray for a sense of unity as we work respectfully and effectively together for the best outcome for our patients. Graciously bless our facilitators with clarity of communication and thought, that we may gain understanding and wisdom to apply all learned to our practices in meaningful ways. We pray for efficient functioning of the audiovisual equipment and an undisturbed transition of the sessions throughout the meeting. Pour your blessings, we pray, on the technical staff, the sponsors, and the moderators as they perform their duties. Grant that we will enjoy another excellent and successful webinar that will impact our daily practice. May your blessings rest on each participant and host as they give of their time to meet on this virtual platform for the benefit of everyone in their care. All these we humbly ask through Jesus Christ and the Holy Spirit. Amen.
Thank you, Dr. Henry Dawkins. And as we continue with our program, please note that our pre-test has been posted and will be available for 10 minutes or so. And we're going to also welcome again, because I see people joining from across the Caribbean. So welcome everyone to this event today. It is for me now to invite Dr. Seni Onenuju, the president of the Caribbean College of Physicians, and to address us now and give us a formal welcome. Okay. Dr. Onenuju, over to you.
Good afternoon, everyone, distinguished speakers, esteemed colleagues, moderators, friends, ladies and gentlemen. It gives me great pleasure to welcome you to today's Non-Communicable Disease and Nephrology webinar. The theme of this afternoon's webinar is the impact of non-communicable diseases on renal function. This afternoon, we will examine two of our major NCDs, diabetes and hypertension, and their impact on renal function. Look at strategies to slow down this progression to end-stage kidney disease, thus improving the quality of care to our patients and achieving better clinical outcomes. Today, our NCDs take center stage as we explore the deleterious effects they have on renal function and strategies to manage them. Both diabetes and hypertension are highly prevalent worldwide, and more so in the older adults aged 65 years and above. As society evolves and continues to evolve, we adopt unhealthy lifestyles that, though suited to today's fast-paced world, remains a key driver in the decline of our health. The development and progression of NCD and the impact they have on associated organ systems such as renal and cardiovascular systems remains a challenge. This afternoon, we'll have the pleasure of partnering with Duke University in the delivery of these presentations. Also, we welcome the contribution of Dr. Aguvaya of Amaji Health Limited, who will be speaking on the Brain Health Navigator certification program, briefly outlining its significance and uses, as we recognize that with an aging population and a rise in NCDs, there also is an increase in declining cognitive function and the need to adopt strategies for their early detection and management. As such, this afternoon we have with us knowledgeable and experienced speakers, Doctors Rasha Rashlam, Komal Safdar, and Kathleen Womack, who all hail from the USA. We wish to thank you for accepting our invitation to share your time, talent, and expertise with us today. We also wish to acknowledge and thank Dr. Aguvaya, who continues to keep dementia research, care, and its related illnesses on the forefront. Drs. Rashlam, Safda, Womack, and Aguvaya, we welcome you wholeheartedly. A sincere thank you to our secretariat staff, headed by Lynn Thompson-Hyatt, and IT team, headed by Mr. Samuel Heron of OK Solutions, who work tirelessly behind the scenes to make this event possible. To our attendees, physicians, nurses, and allied health professionals, your presence here reflects a shared commitment to continuous learning and improving patient care. We also acknowledge and appreciate the contributions of the Accreditation and Programs Committee and the CCFPJ Jamaica chapter members who continue to support and drive medical education initiatives. A special commendation also to Dr. Maynard McIntosh for his invaluable support of the college. And one heartfelt welcome to everyone for the time taken in embracing this session of knowledge acquisition. Without your presence, this clinical meeting would be less rewarding. On behalf of the college, I thank and welcome you all, and I invite you to sit back and enjoy the presentations. Thank you, and God's richest blessings.
Dr. Sene Onanuju, President of the Caribbean College of Family Physicians. Thank you so much for your welcome. And let me also in this moment acknowledge Dr. Ishtar Govaya, formerly. Dr. Aguvaya is someone who we're so familiar with as she takes on this whole, I don't know how we're going to win the battle with dementia, especially with our chronic diseases being on the rise instead of being where they should be in the ground. So, so welcome to her as well. And it is it's for me now to welcome Dr. Rasha Raslan. And I can tell you, this is the shortest biodata, the shortest series I've ever been given to present from. So I absolutely know there's a lot more, maybe books that I could be using to introduce Dr. Raslan today. But I will just use the very, very short 5 lines that I have here. And it is that Dr. Rasha Raslan is a nephrologist working at Duke University Hospital in Durham, North Carolina. And she also serves as the Associate Program Director for the Nephrology Fellowship Program. Her clinical areas of interest include medical education, thank you, renal physiology, and glomerulonephritis. So, Dr. Raslan, we really want to hear from you and give us that vibe. Thank you, everybody who is here and not in Carnival. And Dr. Raslan, please be Carnival. Thank you.
Thank you so much for this introduction. I kept it nice and short and sweet so we can get right into the science of things. Thank you so much on behalf of Dr. Safdar, Womack, and myself. We're very honored to be presenting to you today. We're hoping to teach, but also learn from all of you on the state of, chronic kidney disease and how to manage that in a different healthcare setting. So we're looking forward to learning as much as we are to teaching. So I'll go ahead and start sharing my slides. I have to just go all the way to the back. Okay, can everyone see my slides just well? Perfect. Okay. So we're going to kick off this carnival for today. Was talking about diabetes and chronic kidney disease, and I'll talk specifically about strategies for early detection and management. So I do not have any conflicts of interest to declare. This is an outline of what we'll be talking about. So we're going to talk a little bit about the pathophysiology of diabetic nephropathy and diabetic kidney disease, screening guidelines for early detection, and then talk about really focusing on the management of patients with diabetic nephropathy. And the reason why this is important, as you already mentioned this earlier, is that really diabetes and also hypertension are really the leading cause of chronic kidney diseases, end-stage renal disease in the United States and most developed countries. And I predict something similar would also be in Jamaica as well. And really, at least for the United States, diabetes accounts to up to 50% of the causes of end-stage renal disease. So it presents as a very important modifiable risk factor that we can change to try and protect people from end-stage renal disease. And so this really highlights the importance of early detection to try and prevent progression of kidney disease. So you may or may not have seen this in the past. So this is how we classify chronic kidney disease stages. We have 5 different stages, G1 to G5. And on the left-hand side, you see that the stages are characterized based on your estimated GFR. But just as important is this subclassification where you look at the albuminuria as well. So you have A1, which is very normal to minimal albuminuria, all the way to A3, where you have more than 300 milligrams per gram of albuminuria. So both GFR and albuminuria are important in our characterization of chronic kidney disease stages. So some of the risk factors for the development of diabetic nephropathy include advanced age. And then the 2 most important factors I would say are early onset of diabetes. So if you have someone who has type 1 diabetes starting the age of, childhood or early adolescence, the prolonged duration of diabetes. So if you've had diabetes for several decades, those 2 are very important risk factors in the development of diabetic nephropathy. Other important risk factors include family history of diabetic nephropathy. It is not really clear how exactly diabetes and diabetic nephropathy is passed on from generation to generation, but we know there is somewhat of a genetic component to this. Poor glycemic control is crucial, particularly if it's for a long period of time. And then we have the other classical risk factors of metabolic syndrome, such as hypertension, hyperlipidemia, obesity, and smoking. And when you have someone with diabetic nephropathy, it can often coexist with other end organ damage from diabetes. So these patients can also have diabetic nephropathy and neuropathy. They can have gastroparesis. They can have cardiovascular disease, cerebrovascular disease. And one of the most important correlations that we have with diabetic nephropathy is actually diabetic retinopathy. So around 95% of patients with type 1 diabetes who also have diabetic nephropathy will also have diabetic retinopathy. There's a strong association between the 2. But when you have diabetic retinopathy, it doesn't necessarily mean that you'll have diabetic nephropathy. The reverse is less true. So if you do have a patient who does not have diabetic retinopathy, it doesn't necessarily rule out diabetic nephropathy. But all you need to know is that there is a strong association between these 2. And it's useful to know that if you have a patient who's coming with chronic kidney disease, they have diabetic retinopathy, they have neuropathy, they have gastroparesis, they have long-standing diabetes, then it is most likely that their chronic kidney disease is from diabetic nephropathy. So moving on to the pathophysiology. So with diabetes, there are many changes that happen in the body. You have hemodynamic changes, you have hormonal changes, you have growth factor changes, and all of this creates this environment in the kidney where you have glomerular hypofiltration, you have changes to the glomerular basement membrane, you can have some hypertrophy initially, and some glomerular hypertension. And all of these changes will eventually lead to some podocyte foot effacement, leading to albuminuria, loss of albumin in the urine, deposition of extracellular matrix, and then with time, all of these changes can lead to fibrosis and glomerular sclerosis, which are considered irreversible changes and damage. So I like this figure over here. On the top panel, you see the changes that are happening with a diabetic kidney, and the bottom panel, you have the healthy kidney. So as you can see, you have on the top panel, you have podocyte loss through detachment and apoptosis. All of this podocyte loss, podocyte foot effacement, you may remember this from early medical school days, can lead to albuminuria, increased albumin in the urine. You also have mesangial cell hypertrophy, proliferation, and renal hypertension. All of these changes will lead to what we call as diabetic kidney disease. Now, this is, I think, one of the most important graphs of this talk. So this really shows you on the x-axis the years from diabetes onset. So you're looking here at maybe around 30 years of a patient with diabetes. And on the y-axis, you have their glomerular filtration rate, their GFR. And what we see is that with diabetic nephropathy, really the first couple of years, sometimes you only have microalbuminuria. So that is the early changes that you see with diabetic nephropathy. And in these stages, when you have the first few years of diabetes, when you're having microalbuminuria, typically the GFR is normal or elevated because you have this hyperfiltration that's happening in the early stages of diabetic kidney disease as a compensation. And it's only, with time, after several years, sometimes even decades, that you start having that decline in eGFR. And this is important because this, knowing the pathophysiology and the evolution of diabetic nephropathy, will allow us to screen and detect patients early on to prevent them from progressing to CKD and end-stage renal disease. This is another important graph. This applies to diabetic nephropathy, but also CKD from all causes as well. So here on the lower axes, you have GFR and albumin. And if we take, for example, a patient who has a GFR greater than 45 and low albuminuria, so less than 1 grams per gram, you'll see on the Y or the Y-axis that their incidence of developing end-stage renal disease is quite low. And if you compare this to someone who has a GFR of less than 30 and who has more than 2 grams of albumin, their risk of developing end-stage renal disease is 8 times higher than that first group. So really pointing that the GFR is important, but the albuminuria is just as equally important in determining your risk. We said that a lot of diabetic nephropathy, you start off with albuminuria. It is in rare cases where you can have biopsy-proven diabetic nephropathy with very little to no proteinuria. Why? We're not exactly sure. I would just say for the most part, the rule of thumb is that you have albuminuria first, then you have a decline in kidney function. I wouldn't think too much about these exceptional cases. So what does that mean for primary care doctors, such as yourselves? How do you detect those patients early? So really, the most important thing in screening for diabetic nephropathy is to get that yearly urine albumin. And most recommendations suggest that in patients with type 1 diabetes, you start obtaining this urine microalbumin 5 years after they're diagnosed. So if a patient was diagnosed at the age of 15, you'd start screening at the age of 20. And for patients with type 2 diabetes, you really start as soon as they're diagnosed. The reason is with type 2 diabetes, a lot of these patients have had diabetes for a while, but it may take, you don't know when they're presenting because they're typically asymptomatic with type 2. With type 1, they typically present earlier. You are typically catching them at the time of diagnosis when they first develop diabetes. So just make sure you're getting a yearly urine albumin for your patients with diabetes. Other tests, you're really focusing on management of the diabetes itself. So you want to get a hemoglobin A1C every 3 to 6 months, depending on how well controlled their diabetes is. Make sure you're doing the other things for their diabetes as well. So making sure they're getting yearly eye exams, monofilament tests, and all the things that you typically do for patients with diabetes without kidney disease. So this is where the bulk of the talk is going to be focused about treatment. How do we treat patients with diabetic nephropathy? And I really like this figure over here. which is from some of our nephrology guidelines, showing the pyramid of the things that we need for management of patients with diabetes and chronic kidney disease. So at the bottom of this pyramid, you see kind of the basics, the lifestyle and self-management changes that all patients in our primary care clinics should be focusing on these lifestyle changes. So you have things like diet, where you're really focusing on a low salt, low carb diet for their diabetes and for their hypertension, making sure they're getting enough exercise. Those who are obese, that they're working on a weight loss program, and obviously things like smoking cessation and other drug cessation. Then you go to the second level of our pyramid, where we're talking about first-line drug therapy. So these are the things that you really want to make sure all your patients with diabetes are on. So all patients with diabetes, first-line drugs, if they can tolerate it, is typically metformin. This is with or without kidney disease. We start them on metformin. And then one of the more important drugs we also have is RAS blockade. So things like ACE inhibitors, ARBs, for both the hypertension and to prevent diabetic nephropathy. So this was one of the earliest studies published in 2001, where they looked at ARBs, particularly irbesartan, compared to placebo, and its effect on reducing the incidence of diabetic nephropathy. So here they compared placebo compared to 150 milligrams of irbesartan compared to 300 milligrams or max dose of irbesartan. And as you can see, compared to placebo, the high dose irbesartan had the lowest incidence of diabetic nephropathy, and this is over 24 months of follow-up. So this was really the study that showed the importance of having some sort of RAS blockade in patients with diabetes to prevent diabetic nephropathy. So from a primary care standpoint, these are some of the things you need to keep in mind when you're prescribing an ACE or an ARB, ACE inhibitor or an ARB. So start this on all patients with diabetes. Even if they don't have proteinuria or they have minimal proteinuria, you really want to start this medicine before they develop overt proteinuria. You're trying to do this prophylactically. When you start an ACE inhibitor or an ARB, you can have changes in your serum creatinine and your potassium. So typically you want to get labs checked, creatinine and a potassium or a chemistry panel within 2 to 4 weeks of starting this, or if you're making any dose adjustments, if you're doubling the dose, for example. And even if you do have a rise in the serum creatinine, you can typically tolerate it and push through unless there's a significant rise where it'll force you to stop the medication. So we typically say you keep the medication going unless there's an increase in the serum creatinine by more than 30%. And when you do start an ACE inhibitor or an ARB, you really want to get to the maximal tolerated dose that's possible, provided there's no hypotension. And in patients, and particularly in young females, you do want to advise contraception. And you do counsel the patients that if they do happen to get pregnant while they're on an ACE or ARB, they need to stop the medication immediately, because we can counsel and people will still get pregnant. So just counsel them to stop the medication if they are on it. And then finally, you may, and this is typically in patients with more advanced kidney disease where you can see hyperkalemia. If you do have hyperkalemia, unless it is really significant, there are ways to manage it by starting a potassium binder, by counseling on low potassium diet. You really want to keep the medication going unless you absolutely have to stop it. So these are some of the things that from a primary care standpoint, you need to keep in mind when prescribing an ACE inhibitor or an ARB. Next on our first line list of medications are the SGLT2 inhibitors, so the sodium glucose transport 2 inhibitors. So just a little brief reminder of how SGLT2 inhibitors work. So you have in the proximal convoluted tubule of the nephron, you have the SGLT2 transporter, which is responsible for glucose reabsorption and sodium reabsorption. And so when you inhibit this, you're going to have glucosouria, so glucose being wasted in the urine, and you're going to have sodium that's going to be wasted in the urine. And you're going to have, with the sodium, you're going to have diuresis. So you're going to have all these effects leading to all these changes that you see on the right panel. So you're going to have lower blood pressures, not by much. You're going to have some slight weight decrease. You're going to have decrease in the blood glucose levels. and you're going to have decreased insulin resistance. So this is all the mechanisms through which SGLT2 inhibitors work. And one of the earliest trials that looked at SGLT2 inhibitors, particularly empagliflozin, was EMPA-REG, published in 2015. And here they were looking at the effects of SGLT2 inhibitors regards to specifically cardiovascular disease. But here I put this graph here because as you can see, compared to placebo, the empagliflozin, whether it's 10 milligrams or 25 milligrams, did achieve better hemoglobin A1C levels compared to placebo. And as you can see, there's really no significant difference between the 10 milligrams and 25 milligrams. But it wasn't really until EMPA-KIDNEY, which was published 2 years ago, this was a landmark trial, where instead of looking at cardiovascular disease, they looked at kidney disease. And so here you see that compared to placebo, patients on empagliflozin at the 36-month mark had a higher estimated GFR compared to placebo. I do want to draw your attention to this early part. So as you can see, in the first 12 months of starting the medication, on average, patients who were on the empagliflozin had a lower GFR compared to placebo. So this is an expected side effect that you could see. But if you look at the long-term effects at around 36 months, patients on the SGLT2 inhibitors had the higher GFRs compared to placebo. So it all evens out in the end. So what are some practice considerations for you all when you're starting an SGLT2 inhibitor? So with subsequent trials, we've been lowering and lowering the starting point at which we can start SGLT2 inhibitors. So now we start it on patients with an eGFR of 20 or less. We're hoping with time that there'll be more trials and we can even start it on patients on dialysis or kidney transplants. So for now, started on patients with a GFR of 20 or more, and even with minimal albuminuria. Things that are some potential contraindications, and I would have a really risk-benefit discussion with the patients. So patients who have genital risk infections, so typically patients who are really obese, who have very poor hygiene in the genital region, I may consider not starting. And then there's also the phenomenon of the euglycemic ketoacidosis. So these patients can develop diabetic ketoacidosis with normal glucose levels. You want to particularly choose these medications in patients who have both diabetes as well as heart failure with reduced ejection fraction. And as we said earlier, you anticipate that there will be a drop in the GFR, and you typically keep it going unless it's pretty severe and sustained. So I counsel all my patients when I start this medication, so don't be alarmed if your if your labs show a decrease in the GFR, because a lot of them start panicking. So keep it going unless there's a significant drop. Also, educate your patients on sick day protocol. So these patients, you want to counsel them if they're having, if they're sick, if they're having, nausea, vomiting, or volume depleted, that they want to hold their SGLT2 inhibitors and not take it at home. And then similarly, because we don't have a lot of data, we advise contraception in these women and we stop it if they become pregnant. And this is more because of a lack of data. So going back, so we talked about the RAS blockade, we talked about the SGLT2 inhibitors. Next, we have statins. So there have been numerous trials over the years looking at the benefits of statins in patients with chronic kidney disease. Some trials showed no benefit, some trials did. I'm going to point out the one that did show a benefit. So this is the SHARP trial published in 2011, where they compared patients on simvastatin plus ezetimibe compared to placebo, and these patients had a lower risk of cardiovascular events. So most of us our patients who have diabetes and chronic kidney disease do have another indication for a statin. They typically also have cardiovascular disease, hyperlipidemia. So it's not surprising if all of these patients do end up on a statin as well. And this is based on our nephrology guidelines, where any patient above the age of 50 with a GFR of less than 60 but not on dialysis with diabetes to be started on a statin or a statin and ezetimibe combination. Okay, so now we're going to go on to the third level of the pyramid. So this is additional drugs that have both heart and kidney protection. So SGLT2 technically should be there as well because it does have both heart and kidney protection, but we'll go over these. So the new kid on the block is the GLP-1 receptor agonist. So these have really changed how we manage diabetes and obesity. And so this is just a brief schematic of how GLP-1 agonists work. So they work on multiple organs. So they work on the blood vessels, causing a lower blood pressure. Again, this is not significant enough typically to cause issues with hypertension. They act most importantly on the gastrointestinal tract. So you have decreased gastric emptying, decreased chylomicron secretion. So not surprisingly, many of the side effects of GLP-1 agonists are nausea, vomiting, difficulty tolerating food. They also work on the pancreatic islet cells where you have an increase in insulin secretion and a decrease in glucose. That's also how it causes decreased glucose levels. And then they act on the central nervous system by reducing appetite. So through all these different systems, you have decreased serum glucose levels and then eventually weight loss as well. And the big trial that really showed the benefit of the GLP-1 agonists in kidney disease was the FLOW trial that was published exactly a year ago in 2024, where compared to placebo, patients who were on semaglutide, a type of GLP-1 agonist, had a decreased risk of first major kidney disease event. So whether it was progression of their chronic kidney disease or ending up on dialysis. So there was a statistically significant benefit compared to placebo with these GLP-1 agonists. This graph looks very similar to the one with the SGLT2 inhibitors. So here, when we're looking at the weeks of being on the medication compared to the eGFR, we also see that in the first 12 months, there's a decrease in the GFR in the GLP-1 agonist compared to placebo. But if you look with time, the patients with the semaglutide had a higher GFR and had the better kidney function by the end of the study. So really, just like the SGLT2 inhibitors and just like our ACEs and ARBs, we tolerate an initial decline in kidney function because in the long term, these medications are more beneficial. And so for our patients with type 2 diabetes and chronic kidney disease who have not achieved glucose control despite metformin and SGLT2 inhibitors, we recommend adding GLP-1 agonists. So really your first line therapy for a patient with diabetes and chronic kidney disease, metformin, SGLT2 inhibitors, and then GLP-1 agonists. And this is particularly beneficial in those who have obesity and you want to achieve weight loss as well. So some practice considerations for GLP-1 agonists, you can really start at any GFR. We're actually starting it on a lot of our dialysis patients as well. Some potential contraindications, so patients have a history of pancreatitis or one of those inherited disorders that include pancreatitis, such as MEN, and patients with type 1 diabetes. And you do want to choose this in patients who have diabetes and heart failure with reduced ejection fraction because of its cardiovascular benefits as well. And just like all the other medications, we anticipate an acute drop in the GFR, but unless it's severe, do not stop, keep it going. And so going back to the pyramid, on the top part of the pyramid now, we're going to, before we get to the top part of the pyramid, we have the mineralocorticoid receptor antagonists. I forgot about those. So there have been two big trials, the Fidelio and the Figaro trial, where they were looking at the non-steroidal mineralocorticoid receptor antagonists, so finerenone compared to spironolactone, for example. Not really statistically significant. You do see a trend towards finerenone when it comes to chronic kidney disease outcomes. So the data is not as robust for these non-steroidal mineralocorticoid receptor antagonists, but we do add it in patients who have persistent proteinuria. So you want to try and max out on all your medications that are going to reduce proteinuria. And I would say I would include this as kind of fourth line after all the other medications we talked about. Now we're going to talk about glycemic control. This is really one of the most important things that we can do early on to try to prevent diabetic kidney disease, but also all end organ damage from patients in patients with diabetes. So this is where they're looking at, on the x-axis, you see their hemoglobin A1C levels, and you see the portion of patients, and then on the right side, you see microalbuminuria. And you see that, not surprisingly, patients who have higher hemoglobin A1C levels will have higher microalbuminurias. We talked about this earlier on. This microalbuminuria is a result of increased from uncontrolled diabetes. So the more uncontrolled your diabetes, the more likely you're going to have microalbuminuria, and then the more likely you are going to have diabetic kidney disease and nephropathy. So this is a really, really old study from '93 looking at intensive versus conventional control of diabetes. And what they saw was in the patients who had more intensive diabetic control, so lower hemoglobin A1Cs, they had a lower incidence of developing microalbuminuria. And so in the intensive group compared to the conventional group, they had a reduction in their urinary protein by 34%. So you do want to try to aim for as normal or as tight of a glucose control as possible. And this is where they're looking at not necessarily kidney disease outcome, but mortality, where also intensive treatment of their diabetes compared to conventional, you had lower risk of mortality compared to the others. Just a few caveats on advanced kidney disease and in patients with diabetes. These are really important points to keep in mind. So the kidneys are responsible for around 20 to 25% of glucose production. So in patients who have advanced kidney disease, and this is what we typically see in patients who have a GFR of less than 20, so stage 4 and 5, because their kidneys are not working as well, because they're losing nephrons, they are producing less glucose. So a lot of these patients come to me and they're so happy because their glucose levels are dropping, but they don't realize that it's because of their advanced kidney disease, because they're not producing as much glucose. The other thing that we start to see in a lot of these patients is that patients who are on insulin, they start noticing episodes of hypoglycemia. Again, because for multiple reasons. A, they're producing less glucose because they have less kidney function. And B, because insulin is cleared by the kidneys. And so when your kidneys are not functioning as well, your insulin hangs around in the body longer, causing hypoglycemia. And so in a lot of our advanced chronic kidney disease patients, it is important to keep an eye on their insulin requirements, and it typically needs to be decreased with time. So just making sure that you focus on these patients and are monitoring their diabetes and decreasing their insulin requirements as needed. And then finally, just a little caveat is that the hemoglobin A1C that we typically use to monitor for diabetes control, it can be inaccurate in patients with advanced kidney disease. We know that the hemoglobin A1C is related to your hemoglobin. It's the glycosylated part of the hemoglobin. And in our patients with chronic kidney disease who have anemia from their chronic kidney disease due to less erythropoietin, their red blood cells will have a shorter half-life. And so the hemoglobin A1C may be falsely low. So all of these are things to keep in mind in patients who have more advanced chronic kidney disease. So I really wanted to end with this slide here because I think it's very useful highlighting this. One more thing we didn't talk about is the blood pressure control. So a lot of our patients, almost all of our patients with diabetes also have concomitant hypertension, particularly our patients with type 2 diabetes who are older. And this is the ACCORD trial. This is one of the earliest trials done in 2010 where they looked at patients with diabetes and kidney disease, and they looked at intensive versus standard blood pressure control. Intensive group was a goal less than 120 systolic. The standard was less than 140 systolic. And what they saw is the primary outcome was a composite outcome of cardiovascular disease and all those things, and that the patients in the intensive group had a lower primary outcome compared to the standard group, but this was not statistically significant. Fast forward to last year, this BP Road trial where they also compared intensive versus standard, so less than 120 versus less than 140 as the goal. And here, compared to the standard treatment, the patients in the intensive treatment, so less than 120 systolic, had lower incidence of a cumulative hazard of a primary outcome. Again, this primary outcome was mortality, lower cardiovascular events, and all those things. So typically our patients who are younger, you do want to aim for stricter blood pressure control. Patients who are older, and we'll talk about it in the next lecture, obviously your goals can be a little different because you're trying to balance it out against the risk of hypotension and other things in the elderly. So young patients who can tolerate it, you do want to aim for more strict blood pressure control. This is just kind of ending it here. Remember the basics of all the treatment. You do want to focus on lifestyle first. And then you want to do that first line drug therapy. So metformin, SGLT2 inhibitors, RAS blockade, and statins. If they continue to have uncontrolled diabetes, then you add the GLP-1 agonists. You can add the mineralocorticoid receptor antagonists if they have persistent proteinuria. You want to make sure that their glycemic control their glucose levels are well controlled, blood pressure is well controlled, and their hyperlipidemia is well controlled. And that is it. That is how the things that you need to focus on with diabetic nephropathy.
That's it, Dr. Aslan. Well, thank you so very, very much. And you've taken us rapidly through a very detailed and comprehensive presentation on how to manage our patients with kidney disease, especially chronic kidney disease, I think. And there's so much to note. It's a lot. And you covered stuff for hypertension as well, and how the two, we've got to control both things for best outcomes. You started off with sharing with us a slide on sort of, what was that? No, praxis considerations that we really need to hold on to. And of course, we got to do, as you said, lifestyle. In Jamaica, you know that we are big ladies. A lot of us, we like, Jamaicans eat a lot. We like our food. And it's also a cultural thing, fluffy women. So, yeah.
That's where education comes in, right? To balance the fluffiness versus the diabetic kidney disease. It's a risk benefit.
Yes, so, that's why we need to hear from you, and that's why we need to also be able to share this information widely. And so I'm glad for our nearly 200 participants. It's not quite there, but we're getting there this Carnival Day. And yes, lifestyle, RAS blockade, SGLT2 inhibitors, statins, and finerenone. Yes, it's new in Jamaica. We haven't had it for too long.
And I would say with the finerenone, this is really like later down in the
fourth line.
And I personally, because of the cost of finerenone, I don't even bother with finerenone. I do spironolactone. The mechanism is the same. There are some differences in them. Obviously, you don't have the side effects that you have spironolactone, like the breast enlargement that might bother some people. But for all purposes, I would just start any mineralocorticoid receptor antagonist. So spironolactone should be fine in reducing the proteinuria.
Sure. Right. And just to say too, our GLP-1, which is hardly available.
I was curious to see what the situation is in Jamaica, because here for us it is also hard to have insurance companies approve it. With diabetes, it's approved in patients for just obesity. It is very hard to get approved. And even then, sometimes it's too much of a cost. We're hoping with time that this will change, especially the benefits that we're seeing.
Because yes, the benefits, and it's just not, patients come from overseas on it, but it's not readily available. And then it's, as you say, it's not on our national health fund. It's extremely expensive when it can be accessed. So I just want to thank you again for this lovely carnival of information that you've shared with us in such a striking manner. And we will be back at you with questions in our Q&A session. So before I introduce our next speaker, I'd like to, and yes, Clap, clap, clap. We say thank you. And I'd like to introduce the little segment here where we are going to run Caribbean College of Family Physicians promotion, trying to get those of you who are participants who are with us today to actually listen, like, and join our association, which really does a lot with continuing medical education, keeping you on your feet in this setting, and just keeping you ahead of what's happening generally so that you offer the best to your patients in terms of your skills. So let me ask Sam to share that. No, thank you, Sam.
Guardians of Caribbean Health, the vital role of family physicians. Across the sun-kissed islands of the Caribbean, family physicians stand as pillars of their communities. They are the trusted caregivers who know their patients by name, their histories, and their families. These dedicated professionals provide comprehensive medical care throughout their patients' lives. From the bustling streets to the tranquil shores of the Caribbean islands, family physicians are the first line of defense against illness. They treat a wide range of conditions, from common colds to chronic diseases. They are also instrumental in preventative care, promoting healthy lifestyles and early detection of potential problems. The importance of family physicians extends beyond their clinical skills. They are deeply embedded in their communities, understanding the unique cultural and social factors that influence health outcomes. This intimate knowledge allows them to provide care that is both effective and culturally sensitive. In a region facing challenges such as limited healthcare resources and rising rates of chronic diseases, the role of the family physician is more crucial than ever. Their dedication, compassion, and expertise are essential for building a healthier future for the Caribbean. A legacy of care, the Caribbean College of Family Physicians. For over 2 decades, the Caribbean College of Family Physicians, or CCFP, has been a driving force in advancing family medicine across the region. Established in 1987, CCFP is dedicated to improving the health of Caribbean people by promoting and maintaining high standards in general practice. The organization achieves this through education, advocacy, and fostering a strong network of family physicians. At the heart of CCFP's mission lies a commitment to people-centered, continuous care. This approach recognizes that healthcare extends beyond simply treating illness. It's about understanding the individual needs of each patient and providing holistic care throughout their lives. CCFP provides its members with valuable resources, including continuing medical education, professional development opportunities, and access to the latest research in family medicine. These resources equip physicians with the knowledge and skills they need to provide the highest quality care to their patients. Through its unwavering commitment to excellence in family medicine, CCFP plays a vital role in shaping a healthier future for the Caribbean. Its work empowers physicians to be effective leaders and advocates for the well-being of their communities. Global impact, regional action, CCFP's partnership with WONCA. The Caribbean College of Family Physicians recognizes the importance of collaboration in addressing global health challenges. CCFP is a proud member of the World Organization of Family Doctors, or WONCA, a federation of 131 member organizations representing over 500,000 family doctors worldwide. This partnership with WONCA provides CCFP members with access to a global network of family medicine professionals, fostering the exchange of knowledge, best practices, and innovative healthcare solutions. It also allows CCFP to contribute to the development of international standards for family medicine education and practice.
CCFP's commitment to regional action is evident in its active involvement in shaping health policy in the Caribbean. The organization has been instrumental in key health policy meetings, including the Nassau Declaration on Health and the Port of Spain Declaration. These declarations address critical health issues facing the region, such as non-communicable diseases and the social determinants of health. By actively engaging in regional and global health policy discussions, CCFP ensures that the voice of Caribbean family physicians is heard and that the unique healthcare needs of the region are considered.
If you are a family physician committed to improving the health of the Caribbean people, we encourage you to join the Caribbean College of Family Physicians.
CCFP membership offers numerous benefits, including continuing medical education,
professional development opportunities to enhance your leadership skills, advocate for your patients, and contribute to the development of healthcare policies,
research and publications,
global connections.
Join CCFP today and be part of a movement that is shaping a healthier future for the Caribbean.
Together, we can make a difference.
Join the Caribbean College of Family Physicians and make a difference. Thank you.
Well, thank you all for watching this. I hope that those of you who may not be members of the Caribbean College of Family Physicians and who are in this region, please use this as an opportunity to join with us so that you can enjoy many more opportunities like this one to share and gain knowledge and to have debate and question, which is how we learn. And to move on with this in mind, it is for me to now introduce to you Dr. Kamal Safdar. And Dr. Safdar is another individual with 6 lines by which we will introduce her. And she's going to present on hypertension and cardiovascular renal syndrome, understanding the heart link. And she is is it from Virginia, or is it that, are you from Virginia, Doc?
I went to medical school at VCU, Virginia Commonwealth University.
Okay, all right. So she received her medical degree from Virginia Commonwealth University School of Medicine, and she completed 1 year of nephrology fellowship at Duke University. And she will be returning to complete this in July of this year. And she is currently a chief resident at the Duke Internal Medicine Program. Okay, for the Duke Internal Medicine Program. And she works there as a primary care physician at the Duke Outpatient Clinic and as a hospitalist. And we're going to ask her to just describe exactly what a hospitalist. It's a new word for me, so tell me a little bit about what a hospitalist does aside from her other role as primary care physician, which is one that we like to big up. So Doc, over to you as you do your presentation, but you can also tell us what exactly you do. Thank you.
Yeah, no, absolutely. Thank you so much for the introduction. And so, yes, I work both at a primary care clinic, that's the Duke Outpatient Clinic. I've been working as an attending there, and I work with our residents there. And then as a hospitalist, that's just the fancy term that we use where we work on the inpatient wards. And so all the general internal medicine admissions and day-to-day care, I rotate in the hospital as well. And I work a lot with residents because right now I'm one of the chief residents. So it's a good glimpse and point of view to be doing both primary care and nephrology. So thank you so much for having me. I'm going to bring up my PowerPoint here. All right. And so it's wonderful that Dr. Roslin went first because a lot of this, will honestly be spaced repetition because it's hard to really separate all the things in kidney disease. But I'm going to first be talking about hypertension, and then I'll be talking about the cardio-renal link. Hopefully you guys have some coffee because this is a 50-minute session, but I'll try to be engaging. So I have no disclosures. As for the outline today, I'm going to go over some epidemiology and specifically focus on the Caribbean and Jamaica. I'm going to go over some hypertension basics, then talk about the hypertension and CKD link and management. Then I'll get to the cardio-renal part. And then honestly, I'm actually going to spend a lot of time on cases because I know this can all get jumbled, and hopefully some of the cases can really help put all of these meds and everything together and end with a good summary. So my objectives for today, one is to appreciate the prevalence and morbidity of hypertension, CKD, cardiovascular disease, develop an approach on how to initiate blood pressure medications, especially through the lens of having CKD, knowing the indications for all the cardiorenal protective medications, and I did just want to introduce APOL1 and its relation to hypertensive kidney disease. So I'm going to start off with a case, and this is going to be a very typical basic case. You have a 50-year-old male comes to your office, new patient. He hasn't been to a doctor in a few years. His blood pressure is 154/86 on 2 checks. He says he had a similar value at the dentist recently. The only labs you have are from 3 years ago, and it shows a creatinine of 1.0. And so this was one of your pre-test questions on what would you do next. Would you talk about lifestyle? Would you go ahead and start some blood pressure medication, or would you check some labs first? And so let's go through some information and hopefully can help convince you on what the right answer is there. But first, I want to talk about some epidemiology. And, I was just looking at all the wonderful things in Jamaica, the Caribbean, and honestly, I hope I can visit one day. Just all of you talking about the food, Carnival Day and everything. Looks like such a wonderful place. But we want to keep it wonderful. And, I just want to go over some of the data that I found. And so this was from 2005 to 2006. And you can see that the top 3 causes of years lost are diabetes, strokes, and ischemic heart disease. And hypertension, of course, being huge risk factors for those two, for strokes and heart disease. You can also see here that chronic kidney disease is the 7th leading cause of years lost. And it's increasing. This is the change over that decade, and there's a 28-fold increase in CKD along with these top 3 risk factors up there as well. And if you bring this to more recent data, so this is from 2011 to 2021, it's actually moved up as the 6th leading cause of death, and it is also increasing as well. This is also just the most recent data in terms of the risk factors that are driving death and disability. And again, you can see that diabetes, obesity, and high blood pressure are going to be the top 3 there. So really important topic. And then talking about ESRD specifically, I know Dr. Roslin talked about this, and this is, from a Caribbean registry, so 2006, and they looked at all patients on dialysis, and 65.5% of them was due to hypertension, with the other ones being diabetes and glomerular disease. I will say this is probably an overestimate, since I think there's probably less biopsies, genetic testing that's done, but it's still a significant amount of patients on dialysis, and just thinking about quality of life, cost. And it's wonderful that in the primary care setting, the reason I love it so much is that we can do things to prevent this and really delay it for years if we start early. So let's talk about hypertension. Just so we're all on the same page, I wanted to make sure we all have the same definitions. So normal blood pressure is going to be less than 120/80. Elevated is if you're greater than 120/80. Stage 1 is going to be greater than 130/80. And then stage 2 hypertension is going to be greater than 140/90. As far as blood pressure goals, I know before I get there, one thing that's really important, in all these studies, I know Dr. Roslin mentioned some of them as well, is to make sure that the blood pressure is being measured properly. I know that this is such a simple thing, but it's actually so important, because these are the numbers that we are using to change management and add medications. And so, this is from the AHA, but basic things: you want the patient sitting for at least 5 minutes, back against the chair, feet flat on the ground, all these things. You don't want to be talking while you're taking the blood pressure, because really you want to have accurate data to guide your management. And that is what has been done in all these research studies. And I know that's hard to emulate in the clinic setting sometimes, but I think it's a good opportunity to plug that in. As far as the pathophysiology, talking about hypertension and CKD, I'm actually not going to talk much about this because I want to get into the management, but a lot of it is the same of what Dr. Roslin had talked about, where it's a two-way street. So one is that hypertension can lead to chronic kidney disease, and then chronic kidney disease in itself will worsen the hypertension. So it's really this cycle, and that we want to break that cycle. But the premise is that with the hypertension, you get some nephron damage, and then the other nephrons, they try to compensate, and so you get that hyperfiltration, just similarly like in the diabetes. And so that has high intraglomerular pressures, and we want to use medications to bring those glomerular pressure down to prevent sclerosis and scarring of the kidneys. All right, so this is going to be kind of the bulk of what I wanted to talk about as far as the hypertension component. So here it is. So the blood pressure goal, you'll see different, a couple different numbers out there, but most people are going to aim for a blood pressure goal of less than 130/80, and those are the most recent guidelines from the ACC and AHA. As Dr. Rosin said, though, you want to somewhat personalize this. So if someone has, multiple comorbidities, they're elderly, they're at risk for falls, I will aim higher, whether it's 140s or sometimes 150s. How many years of life do they have left? And we always want to do more, weigh the risk benefits. And in a younger patient, I may aim a little less than that and go to a little bit 120. You'll see another figure where our KDIGO guidelines actually recommend less than 120/80. But I think for all purposes for this talk, we'll use less than 130/80 for our blood pressure goal. Okay, so now that we know our target, so which blood pressure medications should I be using? So this is KDIGO guidelines 2021. And so basically this is saying, if a patient comes in with hypertension, always starting with that lifestyle, that's always going to be the base of everything. And then from there, I want to focus on this middle column here. I don't know if you guys can see my pointer, but so adults with CKD with and without diabetes, this is where I was talking where KDIGO says less than 120, but I think for all purposes, less than 130/80 for the majority of the population is okay. And you can see that the first line medication is going to be those ACE or ARBs. And I think what's really important here is this is in patients even without diabetes. And so, I have this red box here, but you can see A3 or A2 albuminuria recommended, but a stronger recommendation for the A3 albuminuria. And so again, just going to this chart here, all these patients here in this right-hand column who have greater than 300 milligrams per gram, even if they don't have diabetes, they should be on ACE and ARBs. And arguably, if you have greater than 30, if you're in this A2 column as well, you should also be on an ACE or an ARB. I did just want to put this in here because I don't know if all clinics how available the urine albumin to creatinine ratio is to obtain. Maybe someone can tell me in the chat. But just in case, if for some reason, you only have a urine protein to creatinine ratio and you can only check the urine protein there, this is a rough conversion. It's not perfect, but there's a calculator here, but honestly, about 40% of your total urine protein is going to be albumin. So you can just multiply it by 0.4. So if your urine protein to creatinine ratio is 750, you multiply it by 0.4, and then you'll get your urine albumin creatinine is 300. Regardless, I think, the literature and just all the papers, they are really using the urine albumin to creatinine ratio just because it is more specific for that glomerular injury that we're talking about. So I want you to be familiar with both. These are some of the studies that show the benefits of using ACE and ARBs in patients with high blood pressure. And these are studies also that exclude diabetes. And so I really wanted to make that distinction because it's important that we are thinking about this. And so, you're seeing a reduction in your kidney in your composite index, so you're seeing increased benefit in these patients with the ACE and ARBs. So what is the bottom line here after all those words? So you should be using an ACE or an ARB in patients with hypertension and greater than 300 milligrams per gram of albuminuria. And I would actually highly consider it in patients with greater than 30 milligrams per gram of albuminuria as well. As we often know, when a patient gets started on a blood pressure medication, there's a lot of inertia to change it. So I think that's why if a patient is okay with going on an ACE or an ARB for their blood pressure, I will often choose that as first line. And you might be asking, well, why don't we just put everyone, why not just, use an ACE or an ARB on everyone? And, I in the primary care clinic, I'm like, oh man, it'd be so much easier just to start something like an amlodipine and a calcium channel blocker where I don't have to do some lab monitoring, bring the patient back. And so, those are the advantages of something like using amlodipine. But, with using an ACE or an ARB, Practically speaking, after initiating it, you would want to check the BMP 2 to 4 weeks later, and the things that you would be looking for. So hyperkalemia, and then also their GFR. You do expect some bump, but if it's greater than 30%, I'd reevaluate, look for other causes that might be causing that elevated creatinine, and you might have to consider lowering the dose or retrialing later at a time when the patient, after reversing some of those other causes. And then similarly with the hyperkalemia, these are such important medications. Like I mentioned, you are taking, years potentially off of dialysis and even cardiovascular outcomes, which I'll get into. So you really want to try to get these patients on some type of ACE or an ARB. And there's many ways, whether it's diuretics or potassium binders, that you can do to help that. Okay. So, with all of this, the question is that we have these guidelines, but that means that we need to be checking the urine albumin. So what are the guidelines for checking the urine albumin? And so, as Dr. Roslin said, that you will often see, even if you have a normal creatinine, a normal GFR, the albumin is often the first sign of kidney disease. And so, there's several guidelines, but basically they recommend testing a urine albumin to creatinine ratio annually. So once you're diagnosed with hypertension, and then annually in these patients. And so the take-home message here is that you should be checking a urine albumin annually in patients with hypertension, and that is even if you don't have diabetes. And then I also just wanted to put a plug. I know this is not necessarily hypertension related, but just talking about non-diabetic chronic kidney disease that causes proteinuria. The SGLT2 inhibitors still have a role as well. And so if you look at our KDIGO guidelines, they'll say to start an SGLT2 inhibitor even with the urine albumin to creatinine ratio greater than 200, even if you have no diabetes, because that also shows improvement in kidney outcomes. And that correlates roughly to a urine protein to creatinine ratio of 475. And so these are just some of those KDIGO guidelines that I just wanted to put directly there for your reference. So that's where the 200 comes from. And then we'll talk about the heart failure as well. That would be another indication to start an SGLT2 inhibitor. And then I'm just gonna skip the other two here. So what about our other blood pressure medications? So traditionally from our trials, going back to ALLHAT, and these are often the first three medications that we think about when someone presents to our clinic who has high blood pressure. So you have the ACE inhibitors and the ARBs, the calcium channel blockers, and the thiazides. Often patients, this is just like a summary of multiple different studies, and a lot of heterogeneity here, but a significant amount of them also had chronic kidney disease, but really wanted to show that, it often takes multiple blood pressure medications in order to get someone to goal, whether it's 2, 3, or 4. And so, that can sometimes help you, but especially in patients with CKD, they are often needing multiple medications. And so, the one that Dr. Roslin had mentioned that isn't first line is those MRAs, the mineralocorticoid receptor antagonists. And so, when should you be thinking about using them? And I think there was a question kind of in the chat about this as well. And so, we often think of it as the fourth med, if you're having resistant hypertension, to go ahead and start that. But I also want you, again, to be thinking about it in the patient, for example, if they're maxed out on their ACE and ARB, they're on their SGLT2 inhibitor, and they have persistent albuminuria greater than 300. And this is the studies that are done in patients with type 2 diabetes, and that was the Fidelia trial and Figargo trials. And so the positive outcome was in patients with greater than 300. I know someone had asked whether with like A1 and A2, and there's a little bit of a trend of having some kidney protective mechanisms at the lower urine ACRs, but I also don't want to get too much in the weeds. And for now, I'd probably say, if you're having significant albuminuria and you have diabetes, then I would try to put on an MRA, maybe something prior to something like a calcium channel blocker or an amlodipine. And this can be tricky, right? Because if you're putting on an ACE or an ARB, and then you're also putting on an MRA, you can run into issues like hyperkalemia. And that's where things like thiazides can help with that serum potassium. So, all right. A couple pearls that I just wanted to mention. You know, if just coming in all comers, if your blood pressure is greater than 150/90, often you can off the bat start 2 low dose blood pressure medications rather than one to help get them controlled. You do want to try to max out your ACE and ARB if you have that albuminuria. Again, you can use that diuretic to control the potassium. I personally will often start with using ARBs as opposed to ACE inhibitors. One, they just have less side effects. You know, you always get that patient with a cough or maybe that angioedema. And so those are less with the ARBs. So I'll personally go with the ARBs. I don't know which ones are available to you all, but you know, some that are stronger and more longer acting are going to be olmesartan and telmisartan. I did want to mention chlorthalidone. You know, there was some conception like several years ago that it's not going to be effective as your kidney function declines, but the CLIC trial showed that chlorthalidone is effective with your eGFR greater than 15, and it is going to be more potent than hydrochlorothiazide at the same doses. You know, loop diuretics are also effective as well. Don't forget about secondary hypertension. I would say the two that to really look out for if you're going to emphasize. So one is obstructive sleep apnea, and the other one is primary hyperaldosteronism. You know, 1 in 10 of patients who are diagnosed with hypertension will have hyperaldosteronism, and that is going to change your management because you would preferentially want to start something like spironolactone in those patients. And then lastly, compliance is key. You know, I mentioned things like, you know, I have this issue in my Duke outpatient clinic. I can't get patients to come back. I can't do the lab monitoring. Sometimes I get a little bit uncomfortable with prescribing ACE and ARBs. You know, if amlodipine, for example, the thing that you need to do to get their blood pressure less than, you know, the 150, 160 and just, you know, improve that blood pressure, you know, that's reasonable, right? You have to always give your recommendations as the provider, but often compliance is really going to be key. And actually, as I was reading through some of the articles, I was learning about Jamaica and hypertension. There's a very high non-compliance rate, and it's hard. It's hard. I mean, even in our clinics as well. So making sure your patients are taking the medication is going to be the most important thing. All right, so let's come back to our case here to wrap up the hypertension part of this talk. And so you know, I had this question here. This patient's coming in with new onset hypertension. What is your next step? And so really what I wanted to encourage you guys, you know, you're always going to do lifestyle changes, but I want to be using that urine albumin creatinine ratio to really guide your blood pressure medication choice. You know, it might be easy to start something like an amlodipine here, but you know, if this patient has significant albuminuria, I would be reaching for the ACE and the ARBs. So, you know, I'd be checking that chemistry panel, that urine albumin. And just as an example, you know, this patient comes back at 1.2 with their creatinine, urine ACR 500. So I would be starting an ACE or an ARB preferentially, increase the dose as I can to the maximum tolerated, and really aiming for that blood pressure less than 130/80, trying to get that urine albumin down as much as we can. And if the urine albumin is even after maximally tolerating that ACE or an ARB, and they still have significant proteinuria greater than 200, I would be starting an SGLT2 inhibitor as well. My last slide here, just to round off hypertension. So ApoL1, I'm not sure how many people here have heard about it, but it's certainly been a hot topic in the nephrology world. And so ApoL1 mutations, it's basically a gene. And so when you have a mutation in those genes, back in the day, it was advantageous to get rid of African sleeping sickness. Unfortunately, though, if you have 2 of those high-risk alleles, meaning you have 2 mutated alleles, as shown in red here on the right, you're more likely to develop end-stage renal disease. And it's tied to specific etiologies, and hypertension is actually one of them. And so, for example, and this was one of the papers, and in Jamaica specifically, you know, 78% of the population is from African descent. So this is really from West Africa, where these ApoL1 genes are very prevalent, and we can see the migration. And so that's, you know, 200 to 400,000 people who might carry this 2 high-risk APOL1 allele in Jamaica. And so this is cutting edge stuff and things that are going to be on the horizon. So I just want to make sure that everyone has at least heard of it and know to be looking for it, because there's ongoing clinical trials, and some of them have started to show some promise with using targeted medications in patients who have the APOL1 high risk alleles and associated hypertensive kidney disease. All right, to summarize that section, so one, hypertension, it's increasing. It's a large driver of death in the Caribbean. Always be checking your urine protein studies, urine albumin, urine protein if you don't have the urine albumin at the time of hypertension diagnosis and annually. We want to get to that blood pressure goal, less than 130 over 80. Hopefully I ingrained kind of the cutoffs, but if you are greater than 300 with your urine ACR, you should be starting that ACE or an ARB. Start an SGLT2 in patients without diabetes and a urine ACR greater than 200. Patients with CKD often need multiple medications, and then compliance is key. So. Alrighty, well, hopefully you can sip on your coffee a little bit, because we're going to move on to the second half of this talk, which is going to be cardiorenal disease. Cardiovascular disease is only increases as your renal function gets worse. And so that's what you can see here in this graph, that the lower your eGFR, the worsening the CKD, the increased amount of cardiovascular disease. And this is despite adjusting for the baseline cardiovascular disease. And that's same with mortality. Mortalities from cardiovascular disease is going to increase with your CKD stage. And albuminuria in itself, so if you take out GFR out of the equation and just look at that albuminuria, it also increases your cardiovascular mortality. And so hopefully we've convinced everyone here that, the creatinine is important, but the urine albumin is also very important when risk stratifying our patients. And this is pretty, an alarming statistic and graph here. And so this is basically showing that if you have a 25-year-old patient with end-stage renal disease and you compare them to an 85-year-old patient in the general population, they actually have the same mortality risk. And a large part of that mortality is cardiovascular disease. And so that's why it's really important. Yes, we want to protect the kidneys, but we're talking about overall health and what we can do to protect the patient as a whole. And so, with cardiovascular disease, here on this x-axis, I know it's not labeled, but this is basically CKD progression here. And so, looking at the prevalence of different types of cardiovascular disease, you can see atherosclerotic disease is a good component of it. But then when we have the progression of CKD, we see a lot more left ventricular hypertrophy. We see more pulmonary hypertension. You probably see actually a little more out of proportion that have atherosclerotic disease, and you also see some more heart failure as well. And a lot of this is driven, by traditional risk factors, right? There's the smoking, obesity, hyperlipidemia, hypertension, diabetes. But all of this in red, these are kidney-specific risk factors that end up contributing to cardiovascular disease. And so whether that's the uremic toxins, milieu, disordered mineral metabolism, anemia, volume is a huge thing as well. And so all of these are kidney-specific risk factors that are contributing to cardiovascular disease. And honestly, each of these could be its own lecture and how, but that's not really the point here. Just knowing that cardiovascular disease is highly increasing as the CKD progresses. Okay, so then I want to talk about management here. And so, these are the same medications that Dr. Rosalind, I'm glad we mentioned the same meds, because I hadn't seen her presentation before mine, but it shows that, we're all on the same page here. And so these are the 4 class of medications. So we talked about the ACE and ARBs, and we've talked about SGLT2 inhibitors and their kidney protective effects, but they also have cardiovascular protection as well. And similarly, the GLP-1s and the MRAs. And I would say that the data is going to be stronger for patients with diabetes, but in general, we are starting these medications not only protect the kidney, but also to protect from cardiovascular events. Okay, so I'm going to break these up just a little bit. So talking about atherosclerotic disease, which makes up a huge portion of the population with CKD. So this is a really busy slide, but I'm just emphasizing again statins. So, if your patient is greater than 50 years old and has CKD of any stage, you should be starting a statin. And I know we're family med here, so maybe some younger patients as well. So if your patient is 18 to 49 and has any of these other things, you should be starting a statin in them as well. And so I think this just provides a little bit another layer. I know this is probably the graph that is commonly used in terms of who to start a statin in, and kind of like all comers. And greater than 20% for your ASCVD, you're going to be starting a statin. But really, if you're in that 5 to 20%, it's a risk discussion. And what I wanted to highlight, that chronic kidney disease is one of those risk enhancers. So whether you're looking at it from a primary prevention lens or from the CKD lens, statins are going to be key in patients with CKD. There's a question sometimes of aspirin that comes up. There's not a specific in terms of having CKD and starting an aspirin. So this would be similar for all your other patients. So if they have any established ischemic cardiovascular disease, they should be on aspirin as well. All right, so let's talk about heart failure. So this is talking about heart failure in itself and just what the goal-directed therapy is. And all these green blocks meaning that these are level 1 evidence to be starting these medications. And I've starred the overlap with the CKD GDMT, or goal-directed medical therapy. And so you can see that, ACE and ARBs, often with an ARNI, if you have HFrEF, something like sacubitril, I know Entresto is a common one. And again, the MRAs and the SGLT2 inhibitors, and then volume management is going to be key. Looking at HFrEF, so these are patients who have an EF 41 to 49%. So the green box, again here, diuretics is needed for volume management. SGLT2 inhibitors are going to be that class 2A, and the MRAs, the ACE, ARBs, MRAs. There is also some recommendations and some evidence to be on these medications as well. And lastly, HFpEF, and specifically emphasizing this one just because a lot of our patients, they get admitted and they have LVH and coming in with volume overload, and it's going to be a combination due to the heart, due to the kidney. And so diuretics, again, volume management, but SGLT2 inhibitors, a 2A recommendation here to be starting those. And again, some evidence for MRAs and ARBs. And so the reason, if a patient has CKD and, heart failure, this is again going to that KDIGO recommendation. So in patients, we recommend treating adults with CKD with an SGLT2 inhibitor with heart failure, irrespective of the level of albuminuria. So basically, SGLT2 inhibitors, CKD, heart failure, your patient should be on those. All right, so with some of the time that we have left here, I'm going to put it together, and hopefully some of these questions and cases can untangle maybe some of the gymnastics going on in your head. So here we have a question. So we have a 51-year-old male, has hypertension, OSA, tobacco use, CKD. He has been on amlodipine 5 milligrams for 2 years. He does use a CPAP nightly. BMI is 27, blood pressure 134/80. His creatinine is 1.4, eGFR 52, A1C is 6.2%. So this has prediabetes, and the urine albumin to creatinine ratio is 450. And so what would be your next step in management for the blood pressure? So this is a patient, we have blood pressure, they're on amlodipine. They're pretty actually well controlled, right? So you could continue the amlodipine. Maybe it's a younger patient, maybe you want to be a little bit aggressive, maybe you're considering increasing the amlodipine. C would be change amlodipine to olmesartan, and then 4 would be starting one of the MRAs such as spironolactone. Really what the key here is that this patient has significant albuminuria, has greater than 300. So this is a patient without diabetes purposely, right? So I would actually be changing this patient's medication from amlodipine to olmesartan. And this is where it's really important, when you're starting, the blood pressure medications, that first slide that I had, checking that urine ACR at the start, but also annually, because you can develop that proteinuria. So thinking a little bit more about this patient, yes, we did the hypertension, but we also want to think about this patient as a whole. So what else would you be doing for this patient? I know there's only so much time in a primary care visit, so this might happen through a couple visits, but there's a lot of things here. So one is smoking cessation, and so tobacco use in itself is also associated with progression of kidney disease, but also for cardiovascular health. You're going to want to be counseling on smoking cessation. Starting a statin, right? I'm sure if you calculated the ASCVD would qualify, but even just using from a kidney lens, CKD age greater than 50, I would be starting a statin in this patient. Weight loss, obesity in itself, also associated with CKD progression. And so this patient, doesn't have diabetes, so wouldn't qualify for a GLP-1 agonist from that lens, but they do have obesity. And so I know you all mentioned that you don't, necessarily have these meds, but, they might be hopefully coming on the horizon or at some point. So always knowing the recommendations. So with BMI greater than 27 and at least one comorbidity, so in this patient, hypertension, OSA, those would all qualify should be on a GLP-1, or if you have a BMI greater than 30, you should be on a GLP-1 as well. Counseling on the carb diet, this patient has a new diagnosis of prediabetes. If you didn't start the GLP-1, actually there is data on starting metformin in patients with prediabetes as well. That's, just talking more from a primary care provider perspective on that, especially if you're younger. And then, once you are changing this patient to olmesartan, practically what am I doing? I'm bringing them back in 2 to 4 weeks. I'm going to check that potassium, that creatinine, that blood pressure, and increase that olmesartan so I can get to that goal of less than 130/80. And I'll be rechecking urine ACRs at future visits and start an SGLT2 inhibitor if that urine ACR remains greater than 200. All right. So here we have another one. So we have a 43-year-old female, this time has type 2 diabetes, CKD, hyperlipidemia, coming to your office. Medications include metformin and atorvastatin. BMI is 25. Blood pressure is 154/86 on 2 checks. It was 146/74 on the last visit. Creatinine is 1.4, potassium 4.4, A1C is 8.5%. Urine albumin to creatinine ratio is 36. So which medication or medications should this patient be on? All right. So this is a patient with diabetes. So this question is going a lot of what Dr. Roslin had talked about, but basically qualifies to be on an ACE or an ARB, has CKD and diabetes, so should absolutely be on an ACE or an ARB. Similarly, has CKD, so should be on an SGLT2 inhibitor, and then should also be on a GLP-1. And I have kind of the same guideline that's listed there. In terms of like, how are you going to sequentially think about these medications? I would definitely try to, for the hypertension, put them on an ACE or an ARB. Then I'd be starting that SGLT2 inhibitor. And then, I anticipate this patient whose A1C is 8.5% would probably need that GLP-1 agonist as well to control the diabetes. Notably would not qualify based on BMI here for weight loss. All right. So this is another practical question. So 54-year-old male with a history of diabetes is on metformin, empagliflozin, and semaglutide. So is on all 3 great diabetes medications. Is here for follow-up after keeping a home blood pressure log. The blood pressures are consistently the 150s to 160s over 80s to 90s. Creatinine is 1.6. Potassium is 4.6, and the urine albumin to creatinine ratio is 1,400 milligrams per gram. So which blood pressure medications would you start in this patient? Amlodipine, telmisartan only. Go off the bat with 2 medications, telmisartan and amlodipine, telmisartan and chlorthalidone, telmisartan, spironolactone. And so here, what I'm trying to get at, right? This is a patient who has certainly is hypertensive, stage 2, and then has significant albuminuria. And so, when we're talking about blood pressure medications, the two that I would want this patient to be on are an ARB and something like an MRA. But here I'm sitting in my primary care office, and I'd be kind of nervous to be starting both of those off at the same time. Especially, this patient does have some CKD, the potassium is 4.6. And so this is where I think a little bit of some of the art of medicine, comes in. And so, personally, what I would do is, this patient is going to need at least 2 blood pressure medications, when you're up in the 150s or greater. So I would start telmisartan and chlorthalidone in this patient specifically. I would trend the labs, again, the chemistry, looking for that potassium, looking for that creatinine. And then after that, if things look stable and okay, I would be trying to start this patient on spironolactone. So I would be choosing spironolactone as opposed to amlodipine in this patient as my third line agent. And this is where things can get a little bit complicated. And this patient has, a significant amount of albuminuria. And, you can, as family medicine physicians, I want to empower you all to be doing this, but then can also rely on your nephrologist as well for help, especially with managing things like potassium. Alrighty. So here we have a 68-year-old female comes to your office for a hospital follow-up for volume overload. Echo showed an EF of 50% and severe LVH. She was started on torsemide 40 milligrams daily. She also has CKD, hypertension, atrial fibrillation, is on apixaban, and prediabetes. She is on amlodipine 10 milligrams, chlorthalidone 25 milligrams, and valsartan 50 milligrams daily. Blood pressure is pretty well controlled. It's 132/80. Exam shows 1+ pitting edema bilaterally. The creatinine is 1.8. eGFR is 38. Potassium 4.4. The urine ACR is only 10. So what is the next best medication to start here? So how I would frame this hospitalization? I know I touched upon this, but this patient had an EF 50%, severe LVH. This patient has HFpEF. And this patient has CKD. The creatinine is up to 1.8. I kind of made this a little bit, maybe tricky with having a lower urine ACR, but basically this patient has both CKD and heart failure. So this patient should be on an SGLT2 inhibitor. The reason I also wanted to bring this up, I know Dr. Roslin had talked a little bit about the nuances of starting an SGLT2 inhibitor. And so how do you do that? What do you think about, especially in this patient who also has heart failure and some volume? And so, before we get there, I forgot about this. So, we also want to be thinking, this patient is on 3 different blood pressure medications. So, other labs to be thinking about. So again, secondary hypertension, I would be thinking about getting a renin and an aldosterone in this patient as well. But starting an SGLT2 inhibitor. So, these medications are generally very, very safe to start. And there's more and more indications for it, and so I think it's really important for all of us in primary care to really get comfortable prescribing these. And really, the 2 things that I think about are what's highlighted in tan over here, which is what is their status in terms of their blood pressure and their volume status, and then what is kind of their glycemic control right now. And so you can see, if a patient has, if they're normal blood pressure, euvolemic, or maybe they're a little bit hypervolemic, like our patient was, I would go ahead and initiate that SGLT2 inhibitor. And I wouldn't necessarily, this patient was on torsemide 40, so I would not dose reduce the torsemide in this patient that we had, because they have 1+ pitting edema. They also have some, some blood pressure room as well. But you should know when you are already on a diuretic and you're adding an SGLT2 inhibitor, you're blocking the nephron in 2 different places. So you will get increased urine output and some blood pressure effect. And so for this patient, I would feel comfortable just going ahead and starting an SGLT2 inhibitor. If my patient was kind of in this bucket where, they're a heart failure, but they don't have tons of volume, or they're having issues with hypotension, I might go down on that torsemide and go down from 40 to 20 milligrams, and then also initiate that SGLT2 inhibitor. So again, just thinking about volume, And then in terms of glycemic control, you know, we start these patients in patients without diabetes with SGLT2 inhibitors, right? That was kind of the beginning of my talk. That patient with hypertension has that urine albumin creatinine ratio greater than 200, doesn't have diabetes, but I'm still starting an SGLT2 inhibitor. And really the risk of hypoglycemia is really, really like low to zero. And so it shouldn't really be something that you're concerned about. With that being said, you know, if someone is on multiple other diabetes medications and you're about to start an SGLT2 inhibitor, you could consider going down on the sulfonylureas or the insulin by like 10 to 20% as you're starting the SGLT2 inhibitor, but that's because they have other meds that are lowering their glucose. This will also be a little bit of repetition, but you know, I think it's always good to let your patients know what you'll be starting, and you know what are the side effects and the things to look out for. And so I always specifically emphasize the sick day rule. You know, if you get the flu and you're sick and you're not eating, then you shouldn't be taking this medication because there is that risk of euglycemic DKA. And similarly, you know, your patient's going to get, a surgery, a colonoscopy. They should stop the medication 3 to 4 days prior to anything where they'll be NPO or not eating. All right, so time to summarize here. So really, I think this is kind of a high yield slide here. I've broken it up into you have your diabetic kidney disease, and then you have your non-diabetic kidney disease. And so really in patients with diabetic kidney disease, the first sign is often going to be that microalbuminuria. So if they have greater than 30 or any signs of kidney disease, they should be on that RAS blockade, whether it's an ACE inhibitor or an ARB. Similarly, SGLT2 inhibitors, that was going to be your second medication that you're going to add on right away. And then as far as NS stands for non-steroidal MRAs, again, finerenone was the one that was studied, but I totally agree with what Dr. Roslin was saying, that that's a hard medication to get even here. So I'm using spironolactone as well. And so really it's in patients with diabetes, and there's better data, the higher your urine albumin to creatinine ratio is, so greater than 300. Below this, there's not as much data. Again, I know someone asked this. If you read the KDIGO guidelines, technically it says greater than 30, but if you're looking at the actual literature and in practice, I think for me, what makes most sense right now is greater than 300. And then GLP-1s, I know we talked about, but if they're already on metformin, they're already on an SGLT2 inhibitor, still need glycemic control, you should be starting that GLP-1. As far as non-diabetic kidney disease, the cutoffs are a little bit different in terms of the data that's showing kidney protection. So your ACE and ARB greater than 300 for your urine ACR, and then an SGLT2 inhibitor greater than 200, you should be starting this. I will say some nephrologists and other providers are being aggressive, and even with any amount of albuminuria, they are starting the SGLT2 inhibitors as well. But hopefully this is a good slide that can kind of summarize everything we've talked about. And so here's the cardiorenal summary, just knowing that cardiovascular disease is very prevalent in patients with CKD, and that's due to risk factors that are outside of even those traditional risk factors like hypertension, obesity. Albuminuria in itself is independently associated with cardiovascular disease. Using ACE, ARBs, SGLT2 inhibitors, and then also MRAs and GLP-1s, especially in patients with diabetes. And then don't forget about the statin. There's a lot of, the fancy things with the GLP-1s and things like that. But honestly, it's the basics, making sure those patients are on statins, because atherosclerotic disease is a huge part of those cardiovascular outcomes as well. So these are some of my references, and with that, I'll say thank you. I provided my email there in case you have any questions. I'm not very active on Twitter, but I may be soon, so I have provided my Twitter account as well. So I guess X, not Twitter, sorry. And with that, I will end my presentation.
Doc, thank you so very, very much for what has been an extremely comprehensive and compact presentation. And we just want to say, how much we have gained from listening to you this afternoon. Just taking from you the whole idea of what we need to know, the basic basic reaffirmation of the use of our ACE, our ARBs at one level in management, and of course to use those SGLT2 inhibitors, and to note that we don't need to be afraid of the EGFRs, you know, so long as we follow the guidelines. So I'd like to thank you, and I think the case presentations also helped a lot, because you took us through what we see in our office, and you took us through the steps of management. So we just want to say thank you for that. And I'd like to just inform everyone that it poured with rain during Doc's presentation. So I don't know, our numbers haven't gone up to over 200 now, I noticed. Doc, thank you so very much. We are going to come back to you with in the question and answer, which is going to take place at the very end. So we have to actually go through the next session as well. And hopefully we will have an adequate a time to take your question, to take the audience's questions at that time. But thanks again. I think there is so much, so it's going to take the Q&A to really fine tune and tease out some stuff here. There's a lot presented, and it's hypertension, it's diabetes, it's a combination, it's a treatment. So thank you again. We do not have a sponsor at 2:50, so I think that I am just going to go ahead and move quickly forward to turn our session, this session, over to my colleague, Dr. Aileen Standard-Golson, as the second moderator, because we can now use the time to do more Q&A at the end. So Dr. Standard-Golson, we are going to over to you as moderator for the second session. And everyone knows Dr. Standard-Golson. So she's a long-standing executive member with both Caribbean College of Family Physicians, Jamaica and Regional. And she has also been in charge of our med school family medicine program in the she's just gone into retirement recently. So we are very honored to have her with us as our moderator for the next session. And over to you, and please, everybody,
thank you so much.
Q&As.
Thank you so much, Dr. Arna. Dr. Arna Brown-Walker, one of our most dynamic members, always keeping us on our toes. And I am glad we are starting with a little plus on the time side. So we should be able to go through, and the presentations so far have been so stimulating. And I am sure that the two that are to come will be equally stimulating. So it is going to be, the next presentation is on obesity, metabolic syndrome, and the role of lifestyle modification in preventing kidney disease. Always we come back to the lifestyle modifications. Dr. Caitlin Womack is going to take us through that, and she is a resident physician currently training in the Duke University Internal Medicine Residency Program in Durham, North Carolina. She is pursuing a career in nephrology and will be applying into fellowship programs in the summer. Her interests include medical education and health equity. Dr. Womack, we welcome you and we look forward to what you have to share with us. Please go ahead.
Thank you so much for having me. I'm so thrilled to be here and so excited that you all invited me to present today alongside some excellent nephrologists. As a nephrologist, hopeful to be. So let's go ahead and get started. I'll go ahead and share my screen here. It's just loading. There we are. Okay, so today I'll be talking about obesity, metabolic syndrome, and kidney disease. and kind of intervening early to preserve renal health. No conflicts of interest from me or disclosures. The learning objectives from this talk are to describe the impact of obesity and metabolic syndrome on kidney function and CKD risk, to explain the key pathophysiologic mechanisms linking obesity to renal dysfunction, recognize early markers of kidney involvement in obese and metabolically at-risk patients, integrate evidence-based lifestyle and pharmacologic interventions into primary care for the kidney health population. And I do want to say that we've had quite a lot of overlap in some of these talks. Of course, you know, all of these things are very important and run together just intrinsically in terms of obesity, cardiovascular health, and glycemic control with diabetes. So let's get started first with obesity and metabolic syndrome. So as we've kind of discussed a little bit already, you know, obesity and CKD are on the rise globally, and Jamaica is no exception, as well as America, certainly no exception to that rule. The global obesity prevalence has more than doubled since 1990 in adults. And in 2022, about 16% of the global adult population were obese. And that's defining obese as a BMI greater than or equal to 30. And that equates to roughly 1 in 6 adults, which is a pretty staggering number. And the global prevalence of chronic kidney disease as well has risen in parallel. So CKD affects approximately 850 million people worldwide, which equates to about 1 in 7 adults globally. And certainly we know from Dr. Softer's talk, remembering that CKD is the 6th leading cause of death in Jamaica, and obesity was also in the top 3 factors contributing to this. So certainly a relevant issue. And I will just note with that BMI, we traditionally do define obesity based on BMI cutoffs, but it's important to note it is an imperfect measurement. Certainly does not take into account muscle mass, for example. So you do need to be looking at the person in front of you in order to help make the determination as well of obesity. All right. Oop. So now talking about metabolic syndrome. So this is a term that is really closely intertwined with obesity, and it comprises a constellation of comorbidities, which you can see here. Those include a waist circumference greater than or equal to 40 inches in men or 35 inches in women, elevated fasting triglycerides, fasting HDL cholesterol that is low, under 40 in men and under 50 in women, hyperglycemia, which is defined here as greater than 100, and on a fasting blood sugar, and hypertension, which is greater than 130 over 80 or so. And you can see here that these topics are very much interrelated: obesity, metabolic syndrome, predisposed to cardiovascular and kidney disease. And they do so in a way also that are like not only unidirectional, but bidirectional, such that kidney disease, for example, is not only a result of obesity and metabolic syndrome, but can really contribute to a worsening of the metabolic syndrome and to cardiovascular disease in a maladaptive cycle. And because these concepts are so closely intertwined, the term cardiovascular kidney metabolic syndrome has really emerged as a disorder related to the complex interplay between these topics. And this concept of kidney syndrome, metabolic syndrome, is really summarized, I thought, well in this diagram. And I'll direct your attention to the top here. It all kind of starts from excess dysfunctional adipose tissue. And really what we're talking about here is visceral fat in particular. Visceral fat is very inflammatory and really a metabolically active organ. And it secretes pro-inflammatory and pro-oxidative products that damage arterial, cardiac, and kidney tissues. And they do so both directly through vascular dysfunction, but also indirectly through insulin resistance. And this kind of enters a cycle where it causes hypertension, diabetes, and metabolic, steatotic, or fatty liver disease. And then those conditions kind of just further exacerbate that underlying physiology of inflammation and vascular dysfunction, and a really dangerous cycle that leads to both kidney diseases as well as cardiovascular diseases. So now let's talk about the kidneys. So what exactly is happening there with obesity and the metabolic syndrome? The pathophysiology actually starts with that glomerular hyperfiltration that Dr. Safdar already discussed. This is kind of an adaptive response to the obesity and the changes in the kidney, and it leads to something called glomerulomegaly, which can be seen pathologically under the microscope as an enlarged glomerulus with increased capillaries. Over time, the hyperfiltration actually causes kidney injury, and that leads to scarring in the kidney and can manifest as something we call histologically as a focal segmental glomerulosclerosis pattern, or FSGS pattern. And when that's linked directly to obesity, it's termed an obesity-related glomerulopathy. It also causes podocyte damage, and just a quick reminder that podocytes are part of the kidney that are responsible for keeping protein out of the urine. So with the damage to the podocytes, it leads to increased protein in the urine or increased albuminuria. There's also, interestingly enough, a lot of activation of the renin-angiotensin-aldosterone system, as well as the renal sympathetic nervous system in patients who have diabetes or metabolic syndrome, obesity. And I learned in researching for this talk that the adipocytes, which are the fat cells, they actually can secrete themselves angiotensinogen, leading to activation of the RAS system. Downstream angiotensin 2 aldosterone secretion. And then in the kidney, this of course leads to excessive sodium reabsorption in the nephron, hypertension, and it kind of worsens that cycle we were already talking about with the hyperfiltration and the scarring. The adipocytes, as we talked about, is like that principal starting point for this CKM syndrome. They secrete a lot of metabolically active molecules that have been termed adipokines. And these are imbalanced in obesity states, such as too much of the leptin or too much of the adiponectin. And that leads to further inflammation and fibrosis in the kidney through like paracrine or endocrine effects locally. And then lastly, it's interesting that accumulation of ectopic lipids within the kidney actually causes its own damage. The lipid droplets collect within renal cells, including the podocytes, and cause damage to those cells. And also the excess adipose tissue around the kidney can structurally directly compress renal structures, leading to changes in the kidney physiology and contributing to that hyperfiltration and damage. So now let's, it's all fun to talk about the physiology, but let's talk like clinically when you're in clinic, seeing patients on the first line as primary care doctors, what do we all need to be looking out for? First pass, and we already talked about a lot of this in some of the other topics and talks, but certainly bears repeating. We want to make sure we're watching the blood pressure, trending the lipid panels, blood sugars, and A1C values, and the renal function, as well as the weight over time. But as we had already kind of discussed, and as nephrologists giving this talk, you would expect us to bring up the urine quite a bit. So I do want to highlight again that microalbuminuria is really important to check for in patients and can be an early red flag for kidney damage. We already discussed albuminuria a little bit. Just to remind you, it is microalbuminuria in particular is a moderate increase in urine albumin. So that's about 30 to 300 milligrams per day, or a urine albumin creatinine ratio of 30 to 300 milligrams per gram. And it is one of the earliest detectable signs of kidney damage before a drop in GFR occurs, and indicates glomerular hyperfiltration on a more physiologic standpoint, endothelial dysfunction or damage to that basement membrane. And why is it so important? because as we've already discussed in some of the other talks, you know, GFR can initially remain stable or even rise initially because of that glomerular hyperfiltration. The kidney can compensate initially, but as time goes on, there is progressive nephron loss and a decline in GFR with time, leading to CKD and eventually ESRD. So by the time the GFR starts to drop, you've kind of missed the 8 ball a little bit. You know, you have a little bit of irreversible damage that's already occurred. So checking the urine again is just a way to detect that early glomerular injury, so you can kind of intervene a little earlier. And then albuminuria also has been shown to be an independent risk factor for cardiovascular disease as well. So it can help stratify, risk stratify patients from a cardiovascular standpoint, as Dr. Safdar already mentioned. Okay, so now for the bulk of the talk, I'd really like to focus on lifestyle modifications, because we've brought this up quite a bit in the prior talks. And certainly they are our first line management of obesity and metabolic syndrome, and therefore quite critical in preventing kidney disease. But, you know, it's very easy for us to say, oh, lifestyle modification, but what does that actually mean? What should we be recommending to our patients? Well, you know, let's talk about nutrition first. To prevent kidney disease, we really should be using a lot of the same nutrition strategies that we use for everyone to prevent those risk factors that cause chronic kidney disease, the hypertension, obesity and metabolic syndrome, and diabetes. So these include limiting sodium intake as a critical factor, avoiding excessive caloric intake, reducing added sugars and refined carbohydrates. That's more getting at the glycemic control. Reduce saturated fats, and there's evidence behind the DASH and Mediterranean diets as well in lowering CKD risk, which I'll discuss in further slides. So the DASH diet is the dietary approach to stop hypertension diet, initially developed for hypertension, but has actually been shown to be beneficial beyond blood pressure control alone. It is low in sodium and saturated fat, which also do contribute to nephron stress. And it emphasizes fruits, vegetables, low-fat dairy, whole grains, and lean proteins. It's particularly effective in early-stage kidney disease and at-risk populations in particular, such as patients who already have diabetes and hypertension, but who might not have kidney disease quite yet, so that we can try and prevent the CKD. And just a note that sometimes there are certainly high potassium, high phosphorus content in certain DASH foods, which could be problematic in very advanced CKD. So you might want to just kind of monitor those carefully in those patients and maybe collaborate with a dietitian. So DASH diet has been shown to have significant blood pressure impact, as demonstrated through multiple randomized controlled trials. It's been shown to have up to an 11 millimeter per mercury decrease in systolic blood pressure. And it actually in DASH sodium trial, when combined with a low sodium diet, which was less than 1.5 grams in a day, it actually was shown to have additive blood pressure lowering effect in that case. And as you can see in this graph here, as it was adapted from data from the Japanese Society of Hypertension guidelines, but it shows that DASH diet is really one of the most efficacious lifestyle modifications for achieving significant reductions in blood pressure, which we know that from other talks that achieving reductions in blood pressure also reduces your incidence of chronic kidney disease. And in patients, and you know, that's what we see here, lowers risk of incident kidney disease. In one study, among hypertensive patients, high adherence to DASH actually reduced the CKD incidence by up to 50%. That's pretty substantial. Can also reduce albuminuria, and can be also among people who already have CKD, can be linked to a slower decline in the GFR and lower ESRD risk. So essentially reducing that risk of progression of CKD. All of that kind of does make sense when you talk about how think about how hypertension really contributes to worsening kidney disease and development of kidney disease. And then it has a substantial lowering of cardiovascular disease risk, which has been shown in multiple large prospective cohort studies, including that like multi-ethnic study of atherosclerosis. Some of the endpoints in those studies were significantly lower risk of coronary artery disease, stroke, and reduced incidence of heart failure, as well as cardiovascular disease mortality. So a lot of good data for the DASH diet. I'd say bottom line is really excellent for blood pressure lowering effect, and might also have some direct renal protective effects as well. Might want to be a little bit careful in patients with advanced CKD, just continuing to monitor their electrolytes and phosphorus levels. Now, the Mediterranean diet also has a really robust database as well. And it is also characterized by a high intake of vegetables, fruits, legumes, whole grains, nuts, olive oil, moderate fish and poultry, and low red meat and processed food. A lot of these do sound quite similar to the DASH diet. I'd say some of the differences are the Mediterranean diet is a little bit higher in unsaturated fats like olive oils and nuts, and higher in the fish and seafood, and is a little bit more flexible than the DASH diet. It's associated with a lot of good benefits, improved metabolic profile, including blood pressure, sugar, lipid regulation, and weight loss. Also associated with reduced cardiovascular disease and cancer risk. And if you're anything like me, that's kind of the thing that I always think of first with the Mediterranean diet, because that has been shown in multiple studies. What I didn't really realize previously, but is also true, is it is also associated with a lower incidence of CKD as well, and progression of CKD, and also with reduced albuminuria in some observational studies, which again kind of makes sense because we're getting at those downstream or upstream risk factors that do contribute to kidney disease over time, such as the metabolic syndrome and weight. And then, reduced albuminuria as well. And this is kind of so much so that our National Kidney Foundation Kidney Disease Outcomes Quality Initiative, which provides evidence-based guidelines for CKD management here in the US, in their 2020 clinical practice guidelines, they actually do recommend the Mediterranean diet in adults with CKD 1 to 5 who are not on dialysis or have not received transplants yet. Because, and this is even with people who have normal lipid panels, so far, they suggest the Mediterranean diet improves lipid panels, and then it could also decrease body weight, blood pressure, and net acid production. To briefly discuss optimal nutrition in patients who already have CKD to kind of support kidney health, because we do know a lot of people who have CKD are, of course, interfacing with you in the primary care office. Some additional considerations here, a moderate protein intake is typically recommended. There is a lot of variability in exactly how much protein should be recommended based on the stage of CKD. So what we typically recommend for CKD 1 to 2 is pretty much the same as the general population, about 0.8 to 1 grams per kilogram per day. And then at those higher stages, for CKD 3 to 5, it's a little bit, more, it's actually a little bit limited, so 0.6 grams per kilogram per day. The reason that protein intake is recommended to be a little higher in the ESRD population is because there is actually this like reverse epidemiology effect where people with lower weights who are on dialysis, or higher weights who are on dialysis are actually associated with worse outcomes. So we want, and it's kind of because the ESRD in dialysis, it's a very much a catabolic state. So we actually want those people to be building muscle, and we could tolerate a little bit more protein. And we actually want a little bit more protein in that population. But in general, for the people who are not yet on dialysis, we do want to avoid high protein kind of fad diets for weight loss in that patient population. We also want to limit sodium intake with a goal of less than 2.3 grams per day. And, part of that is also lowering your blood pressure as well. Limit processed foods and red meats, because high intake of processed foods and red meats has been shown to lead to CKD progression and mortality through mechanisms like contributing to acidosis and hyperphosphatemia. And really we want to try and substitute those out for plant-based proteins, and fish, poultry are also better alternatives to recommend than the red meats. A little bit about the plant-based eating. So plant-based diet has actually been associated with some better kidney outcomes and metabolic health. And previously there was some fear that like a lot of vegetables could be leading to high phosphorus or high potassium content. And I didn't mention that previously with the DASH, but in fact, there is only about less than 50% bioavailability of potassium and phosphorus in our diet. So typically we're not seeing really robust potassium or phosphorus changes because of that. Now compare that to ultra processed foods. The bioavailability of potassium and phosphorus in ultra processed foods is 100%, or like near 100%, compared to less than 50 in foods. So we really should be telling people as best that we can to avoid these processed foods. And they can kind of hide, like dark sodas, for example, have a lot of phosphorus in them. And the patient might really be wanting to limit sodium intake and grabbing these salt additives, like new salts, for example, is one that's on the market. But those can be dangerous too, because they contain quite a bit of potassium. In fact, this is essentially new salt is potassium chloride, 656 milligrams of potassium in just a fourth of a teaspoon, which is the equivalent of a whole avocado. So, those types of salt additives you have to be really careful with avoiding, in particular in the advanced CKD population, where you're really worried that there could be hyperkalemia and hyperphosphatemia. Our goal is to keep phosphorus and potassium in a normal range. Okay, so let's talk about physical activity now. Now, exercise we know is really useful for a variety of reasons, certainly for reducing cardiovascular disease and metabolic syndrome. The evidence is very strong. It reduces insulin resistance and improves glycemic control, which are very important factors because diabetes, of course, we know is a leading cause of CKD. It lowers blood pressure, improves the lipid panel, decreases chronic inflammation and oxidative stress, promotes weight loss, reduces that visceral fat that we know is quite inflammatory. And there are actually some mechanistic and animal-based studies that show it might improve renal hemodynamics in diabetic patients. So for all these reasons, we do certainly want to recommend physical activity for our patients. And then you get at how much exercise, how much physical activity should we be recommending? And because kidney disease is really intrinsically linked to the rest of our health, we should be essentially recommending what we recommend for everyone. These are the WHO guidelines, the World Health Organization guidelines on physical activity of at least 150 to 300 minutes of moderate intensity aerobic physical activity, or at least 75 to 150 minutes of vigorous intensity physical activity. They also really stress limiting sedentary time and also building some resistance strength training into a person's week, typically recommended at least 2 sessions of resistance training in a week per the WHO guidelines. And again, we see this coming in our kidney disease guidelines as well, that they recommend in the clinical practice guidelines that patients with diabetes and CKD be advised to undertake moderate intensity physical activity for at least 150 minutes per week. Here you can see some examples of what moderate intensity physical activity really encompasses. So that would be like brisk walking, biking, yoga, swimming. That vigorous is more running, biking, swimming, and lifting heavy weights. Additionally, some, as we kind of already discussed, the physical activity that we typically look at in a lot of the trials is that moderate intensity, at least 150 minutes per week, which comes out to about 30 minutes, 3 to 5 times per week or so. And there have been studies that show it lowers the rates of incident CKD, improves quality of life measures and cardiovascular disease outcomes, and it might be associated with a slower GFR decline and lower albuminuria. Although it's interesting, more studies are definitely needed in this space. Resistance training also improves muscle mass and insulin sensitivity, and also more research is needed as to whether or not that impacts your GFR, although it would make sense kind of based on everything we've discussed previously that it would, but a little bit more research is needed in the resistance training space and the impact on GFR. To talk about some other beneficial lifestyle modifications as well, we already mentioned smoking cessation in Dr. Softar's talk, and really we should be advocating for smoking cessation for all of our patients who are smoking. Besides the well-known cardiovascular disease risk, there's evidence from multiple retrospective studies that smoking cessation may be associated with slower eGFR decline and decreased progression to ESRD. So based on this, I think it's fair to counsel all patients that smoking might be beneficial not only from a cardiovascular standpoint, but also from a kidney health standpoint, which might be, even more of an argument for someone who might have a family member on dialysis. A point on ensuring adequate hydration, we hear a lot this myth of the 8 glasses of water a day, but really we want to make sure we're ensuring adequate hydration, but not overhydrating. And really this should be tailored to the patient. So we want to certainly avoid dehydration because dehydration can lead to hypovolemic kidney injury. We want to prevent kidney stones, and keeping up with water intake and hydration certainly can help with preventing stones and subsequent kidney damage in those who are prone to that. But we should be aiming kind of for what I call the light yellow, pale yellow urine that could show us that someone is kind of adequately hydrated and has enough fluid intake in their diet. And just a note for patients who are established or late stage CKD, these are the patients that we're really worried we could overhydrate. So we want to avoid fluid overload, and that's why you have to kind of take into individualize these recommendations for the patient who's in front of you. And then lastly, we should highlight the other options for weight loss as well. So bariatric surgery can come in, as well as pharmacotherapy next in line from after lifestyle modifications have been pursued. Bariatric surgery, so typically they include the Roux-en-Y gastric bypass or the sleeve gastrectomy as our primary options for a bariatric surgery. Typically, these are patients who qualify if they have a BMI greater than 35 or equal to 35, or a BMI greater or equal to 30 with at least one comorbidity such as hypertension, OSA, or diabetes. And there's been evidence that shows that bariatric surgeries improve CKD risk factors like hypertension, metabolic syndrome, and diabetes, and is even directly renoprotective. In some animal models, they've shown that the bariatric surgeries had a reduced renal fibrosis or scarring score, reduced inflammation and oxidative stress on the kidneys. And there are associations with reduced albuminuria as well. And then it was also shown that bariatric surgery could improve or reduce the risk of mortality in patients with CKD who have obesity as well. And I will note also, I found it very interesting that there are beneficial effects of bariatric surgery on kidney function that might not be entirely attributable to weight loss. In a meta-analysis that I found, improvements in albuminuria after bariatric surgery were actually not correlated with changes in weight or glucose levels, suggesting that perhaps bariatric surgery could lead to metabolic changes that improve kidney function that are even independent of weight loss and independent of glycemic control. So for the right patient, sometimes this is a really good option. Of course, pharmacotherapy is something that we've already talked about quite a bit, but to focus kind of on the obesity relevance of these drugs, certainly this is a time where we have a lot of new and exciting drugs out on the market for weight loss. And you can see here a comparison of agents by percent body weight loss from initial weight. Over here on the left, we have the diet and lifestyle. And then on the other extreme, you have the bariatric surgery options. And some of those medications that we've already discussed, which have excellent benefits in CKD, also we know have weight loss benefits as well. Metformin and SGLT2 inhibitors, you can expect about 2 to 3% body weight decrease from their initial weight with those agents. And that's, of course, in addition to their impacts on kidney health. And then certainly we've heard a lot about the GLP-1 agonists and the GLP-1 GIP agonist tirzepatide. And these are really superior agents for weight loss. Tirzepatide is, of course, the dual GLP-1 GIP agonist, and this exerts the most potent weight loss effect, up to 17.8% body weight loss from initial weight. And one note is that these agents actually might have some synergistic effect on weight loss. They have looked at patients, comparing patients treated with metformin and GLP-1 agonist combination therapy compared to people who are just on metformin monotherapy. And the GLP-1 and metformin combination therapy have competed in terms of weight loss, exerted greater weight loss benefit than the metformin and metformin alone. And they've also compared this with the metformin and the SGLT2 inhibitors, dapagliflozin, such that both metformin and dapagliflozin both together elicited greater weight loss than either treatment alone. So a lot of these patients were going to be starting multiple agents anyway because of all of their chronic conditions. But interesting to note that some of these could synergistically impact their weight. And then some spaced repetition. I won't go too much in detail on these just because we've already discussed all of these in quite detail. But metformin, SGLT2 inhibitors, GLP-1 agonists, and dual GLP-1 GIP agonists have a lot of kidney and cardiovascular health benefits beyond weight loss, including reduction of albuminuria. Of course, there is a slight risk of lactic acidosis to be aware of for the metformin. And as I mentioned, it does have about 2 to 3% weight loss benefit for the metformin in patients both with diabetes, but also without diabetes as well. SGLT2 inhibitors, those big trials that we've heard of, the Credence, the DAPA CKD, and EMPA Kidney really showed the improvements in kidney outcomes regardless of pre-existing diabetes or albuminuria. So we should be reaching for those as well. And then, of course, the GLP-1s benefiting cardiovascular disease outcomes as well as kidney outcomes, including reduced albuminuria. And just to highlight again, this FLOW trial just published last year that showed that semaglutide reduced risk of kidney disease progression as well as cardiovascular and kidney death by 24% compared to placebo in patients with diabetes and CKD. And this trial was actually terminated early due to significant evidence of efficacy. So some take-home points from this talk. Obesity and metabolic syndrome are really major modifiable drivers of CKD. The relationship between obesity, metabolic syndrome, and kidney and cardiovascular health is really bi-directional or multi-directional. Lifestyle interventions, including the Mediterranean or DASH diet, physical activity, smoking cessation, avoiding kidney injury, and weight loss are really important for kidney protection. And pharmacotherapy and bariatric surgery might be helpful adjuncts for this. And primary care physicians are on the front lines so that we can have early identification and targeted intervention to really change the course of kidney health for these patients. So there's my references. And I am really thankful for you all for allowing me to speak today, and certainly open for any questions during the Q&A. Thank you.
Thank you so much, Dr. Womack, for that comprehensive but very understandable presentation that you gave us. You reminded us again of the interlinkages between obesity and not only hypertension and diabetes, but also chronic kidney disease. You were very practical in your applications of the lifestyle interventions that are necessary, reinforcing some of what we already know, but also giving us the underlying research evidence that bolsters these protocols that we use. So we thank you very much for a very enlightening presentation. And I will ask members of the audience if they have any questions for Dr. Womack. Please put them in the Q&A section so that we can get to them later on. So thanks again, Dr. Womack. Sam, Mr. Heron, can you tell me, is there a sponsor's presentation now? Or should I go on to Dr. Aguvaya? Just checking if there's a sponsor's presentation to come at this time. All right, getting no response to that.
I'm so sorry. I thought the microphone was working. Sorry, Doc. No sponsor presentations.
Okay, thanks very much.
So sorry.
So there is a special presentation that is going to be done by Dr. Ishtar Aguvaya in relation to Amaji Health Limited. Now, Dr. Aguvaya is a global leader in brain health and dementia care, whose expertise has been recognized with her nomination to the World Dementia Council. She is the founder and CEO of the UK incorporated startup, Amaji Health Limited, which co-develops with partners in emerging markets, data-driven and tech-enabled solution for brain health and dementia care. She's going to give us a brief presentation about this, and immediately after her presentation, we will entertain a few questions for her. So Dr. Aguvaya, could you go ahead and present for me, please?
Thank you so much, Dr. Standard Golson. And I also want to say a special thanks to Dr. Morgan, to Dr. Brown Morgan and Dr. Sani Onunuju as well, and to the CCFP for your continued collaboration. A very special thanks as well to the excellent presenters, Drs. Raslan, Safdar, and Womack, because you've presented research, clinical guidelines, and practical patient management that I think is truly remarkable and helpful for our context. So once again, greetings, colleagues. thank you sincerely. I hope you can see my screen. Please let me know if you can't. Greetings and sincere thanks again for the opportunity to share today. So my message to you today can be summarized in one sentence, and that is that brain health care starts in primary care, and that future brain health work starts right here in the Caribbean with you. So in our primary care clinics, we are expertly managing hypertension, high cholesterol, diabetes, and other chronic conditions. But there is one clinical gap that keeps slipping through, and that's cognitive decline. Cognitive decline is going unrecognized, unaddressed, and unmanaged, and that is costing us all. In our Jamaica Davos Alzheimer's Collaborative site, cognitive screening rates were shockingly low in persons 60 and older. And when done, more than 86% of patients were already in the borderline or impaired range. The opportunity for timely detection and intervention is being missed. And general practice is really where we can flip the script. And this is where Amaji comes in. Amaji Health Limited is a regional social venture focused on brain health equity and real-world change. That's why we created the Brain Health Navigator training program. This is a practice-based training with clinicians at the center of shaping and delivering scalable cognitive care pathways. The Brain Health Training Program is a short, applied certification designed for GPs just like you. This training program is not theory-heavy. It's practical, peer-led, and tied to pilots that you help design. What your colleagues are already doing. Dr. Crystal Binsley, a public sector GP in St. Anne, is launching a geriatric-friendly cognitive care workflow. She's focused on case finding and screening. Dr. Ariel Roberts is focused on upskilling colleagues and caregivers to reduce stigma and raise awareness. And Dr. Lisa Stevens is also focused on a clinical workflow that emphasizes screening and detection. These programs, these training opportunities, give us the ability to ensure that you are gaining clinical and economic value from the teachings, from the learnings. What we're hearing from our trainees is that they are referring earlier and more effectively, they're improving caregiver satisfaction, and they are piloting services that may soon be billable, measurable, and fundable. So this is really value that you can feel. You're not just improving outcomes, you are positioning yourself as the go-to provider for cognitive care in your community. This training is especially powerful if you're in the stage of your career where you're growing your practice, you're mentoring others, or you're expanding your services. So if you have been practicing for 7 to 20 years and you want to stay ahead of the curve, if you're building a niche in aging, primary care, or prevention, if you have seen cognitive decline too often and too late and you want to act earlier, then this is a program for you. And GPs tell us that they gain so many things from this program, including confidence to identify risks for cognitive impairment and manage them effectively, confidence to spot cognitive decline early and screen appropriately, very practical tools that they can use in 10-minute consults, stronger caregiver relationships and clearer referral pathways, and new services for their practices, from memory screening to care planning. So this is not about becoming a specialist, even though we do have specialists who are part of our cohorts. It's about being the kind of GP more families are turning to. A GP that's informed, confident, and ready. And this Brain Health Navigator cohort isn't just training, it's a network. GPs in our first cohort are connecting with consultants, psychiatrists, clinical nutritionists, and public sector colleagues. You can exchange referrals, you can co-design patient pathways, and you can learn from one another, even across sectors. This is why it's a smart and supportive space. And as Amaji leads the way in building out the brain health ecosystem in and for the Caribbean, brain health navigators and trained GPs will be among the first equipped to engage with the opportunities in this ecosystem. These include new care services in development with partners such as the Caribbean Community of Retired Persons and CARFA, the Caribbean Public Health Agencies, as well as other service providers throughout the Caribbean. Whether through home-based screening pilots, workplace micro-trainings, or future clinical placements, we're laying the groundwork now for an ecosystem of coordinated brain health care, grounded in trust, equity, and readiness. And we intend to showcase some of the results from what you brain health navigators are doing at next year's first Caribbean Brain Health Summit in November 2026 in Jamaica. This full program cost is $2,500 US and the equivalent Jamaican, and we offer flexible payment plans. This cost includes all live sessions, peer networks, placement support, weekly supervisions, screener tools, and your capstone projects. You are building a new part of your practice, and Amaji is building it with you. You'll get trained in risk identification and management, so many of the issues that we've been talking about here today, in screening and in referrals for appropriate diagnostic pathways, as well as in multidisciplinary management and coordinated care. So we encourage you to sign up for the waitlist for future cohorts, including those starting in mid-September and in mid-January. And please feel free to contact me directly via WhatsApp to share more about your own practice and your own needs and your vision for how you want to build. We're looking for mid-career GPs who are ready to lead in their clinics, their communities, and across the region. We're also excited to welcome early career and established GPs who see this as part of their future contribution to medicine. So I want to thank you for your time, attention, and interest, and please do reach out.
So much, Dr. Aguvaya. I don't know if there are any questions directly for Dr. Aguvaya. So you say your second cohort of training is starting shortly?
Yes, in September.
In September. And to apply to be part of this, one would need to just go onto your website. Is that it?
Sure, yes. And I'll put up here again the QR code. So I encourage everyone to scan the QR code to go to the tinyurl.com and sign up for that wait list. And once you've signed up for the wait list, then we ensure that once the application period opens, you'll get mailed all of the relevant materials.
Okay, and if you could just go back to your slide that shows the three different, yes, this one. So there are, if we would be taken through sequentially the material, and
yes,
we would get material as well.
Correct, yes. So definitely. So because we are very plugged into the global space in terms of all of the work that's happening in Alzheimer's disease and related dementias, including all of the research and the clinical practice that's happening in research settings related to the new therapeutics, the anti-amyloid and the anti-tau and the combination therapies. And yet still we are also preparing the Caribbean region and the Caribbean as a brain health ecosystem for these therapeutics whenever they are ready to be coming into our market. You also get first access to those types of opportunities, those types of conversations. I'll be very happy to put in the group chat as well the link to our first Caribbean dialogue of the World Dementia Council, which was on diagnosis and health system preparedness. I'll do that as soon as I stop talking.
Right. So and I'm sure, as you mentioned, not only are we getting the knowledge, but we are developing these linkages with a number of other.
Definitely. So one of the big benefits of the program is that, similar to how this webinar today has been structured, with so many amazing colleagues from outside of the region really helping to enhance our learning and our education, you get plugged in through the Brain Health Navigator training program with scholars in Switzerland, with scholars in the US, with scholars in England,
Wonderful.
And with clinicians in these places as well, to help with building out, as well as the neuropsychologists and the others within the Caribbean context. For example, if you wanted to help with the upcoming Jamaica Health and Lifestyle Survey, and the work that we're doing in terms of developing this harmonized cognitive assessment protocol, and you want to be part of that and bolt that onto your learnings with the program, we have many opportunities like that to facilitate.
Wonderful. And I noticed here the 3 scholarships. I imagine that persons would also be able to apply for those on the website.
Definitely,
okay.
Yes.
Thanks. I don't know if anyone else has any.
Yes, Aileen. I just wanted to ask a little bit more about the sort of profile, Dr. Aguvaya, the sort of person profile that would be best suited to your program.
Yeah.
And I just can introduce that into the diaspora.
Yes.
And and what next? Okay, when they do this, and how do you integrate them and move them forward? How do they best position themselves after the
That's
program?
a great question. So the profile is really a clinician who has at least 3 to 5 years of experience, and who is through their own practice has been recognizing these types of gaps as well as the opportunities. And that relates to the second part of your question, because there are opportunities now, and we are building up the care services. So what you're actually being trained in are services that you can pilot at your place of practice, at your practice. You can pilot these things with, or you yourself can take the training program as the lead GP at your practice, or you can have a junior member of your practice take the training and then facilitate a building out of a workflow where you will be supervising and getting some additional support from the wider network, the wider AMAGI network of clinicians, of scientists, to help you ensure that you are developing evidence-based care pathways. So as part of the building out of the ecosystem, and again, this the Brain Health Summit, which is next year, the first Brain Health Summit for the region, is about bringing together leaders, researchers, innovators, and funders. And so what we're aiming to do through these first few cohorts is ensure that we have really strong clinicians who are themselves in a hub and spoke type of model. They're building out the practices, the care pathways in their areas of work and living. And so we'll be featuring their pilot projects at next year's Brain Health Summit.
Thank you very much. Thanks, Dr. Brown Morgan. Could you put back up the slide with the QR code of some persons I think want to capture it? And just remind us the actual course that we'd go through. What's the length of that course?
Another great question. So it's a virtual curriculum delivery, and it's approximately 2.5 to 3 months curriculum delivery. So that includes weekly live sessions, plus you need to do at least 6 to 8 hours outside of those weekly live sessions. That includes watching recordings, doing readings, doing relevant, very practical though assignments. So these assignments include things like what we refer to as insight logs, really your screening pathways and figuring out which tools you're using, how are you helping to identify risk, using things like risk calculators, some of which are relevant for even some of the things that our fellow presenters have already mentioned. And after that 2.5 to 3 month curriculum period, you're squarely focused on your capstone project and building out your pilot, whatever that is. It could be a workflow at your practice. It could be a community-based program. It could be a screening program, for example, with one of our partners, the Caribbean Community for Retired Persons. And in doing that, you are also developing your own billable services. Again, so it's really helping you, not just clinically, but really helping the economic model of your practice as well. And that is for 3 months. And then you present that capstone to the faculty and to invited guests through a virtual presentation.
Thank you ever so much. I am sure that you have piqued the interest of some persons online, and I trust that you will get some take-up from your presentation today. And thank you for your continued work in this area, such an important area for us globally, but certainly here in the Caribbean, as well as our populations continue to age and we are more and more faced with this issue. So thanks very much for taking the time to be with us today.
And thank you so much to Dr. Standard Golson. Appreciate it.
All right. Okay, so we're moving on now to our final presenter. She presented earlier, but I know we have at least 20 persons who were not with us when she was first introduced. So for their benefit and to remind those of us who have been here all along, Dr. Rasha Raslan is a nephrologist working at Duke University Hospital in Durham, North Carolina. She also serves as Associate Program Director for the Nephrology Fellowship Program. Her clinical areas of interest include medical education, renal physiology, and glomerular nephritis. This time around, she's going to talk to us about chronic kidney disease in the aging population. We just mentioned how important dealing with the aging population is, and we're going to look at the challenges and management strategies for chronic kidney disease in this population. So Dr. Raslan, I invite you to present once again.
Thank you so much. I think this is a good topic to end on. Okay, let me hold this up. Does that look good to everyone?
That's good.
Perfect. Okay. So yeah, we're going to end today's carnival on chronic kidney disease in the aging population and what are some of the challenges and management strategies that we have for this very unique patient population. So I don't have any conflicts of interest. These are the 3 main objectives. We're going to talk about age-related changes in kidney function, the burden of non-communicable diseases on renal health in older adults, and then individualized approaches to treatment and care. A lot has already been said about diabetes and hypertension and obesity and how all this plays a role in chronic kidney disease. So we're going to try to kind of focus on this specific elder population after all of this damage and kidney damage has happened. So aside from diabetes, hypertension, and obesity as risk factors for kidney decline, there is also a factor of age-related decline in kidney function. So this is a little independent from all the other risk factors that we talked about. In general, as a rule of thumb, the average GFR in humans starts to decline approximately 1 milliliter per minute per year after approximately the age of 30. So I'm already past my peak. I'm already starting to lose GFR with each year. And despite the decline in GFR, the serum creatinine can remain stable, and sometimes it can even actually decrease. And we'll talk a little bit later about why this can happen. And we don't really know particularly why there's a separate age-related reason for decline in kidney function. There are all these theories that is it from the insults that the kidney is constantly exposed to, so diabetes, high blood pressure, metabolic defects. Is it diet? Is it infection? Is it something in the environment? Inflammation? There are also certain genetic factors that we've identified, something called clotho, which is an anti-aging factor. So many different factors that with time will lead to a decline in kidney function from age alone. And interestingly enough, when they did kidney biopsies on patients without any chronic kidney disease, there was age-related changes in the kidneys. So in these patients, older adults without chronic kidney disease, when they did biopsies, they saw that they had increase in global glomerulosclerosis. So glomerulosclerosis is basically fibrosis of the glomeruli. They had arterial sclerosis. They had atrophy of the tubules, and they had reduced cortical thickness and a decrease in kidney size. So clearly there's something else that's happening to the kidneys as we age that is not necessarily related to chronic kidney disease. It could be from all the other factors that we've talked about before. And this is important because chronic kidney disease is pretty common. It's only increasing with time. So from the time that you're born, your lifetime risk of developing at least chronic kidney disease stage 3A plus, which is the more significant chronic kidney disease, is around 60%. So it's our individual risk of developing chronic kidney disease is quite high. And this is actually greater or similar to our lifetime risk of developing diabetes, coronary heart disease, or an invasive cancer. And so the overall prevalence of chronic kidney disease is around 13% in the general population, which is quite significant. And out of this 13%, it's almost always, not always, but the majority of this population is in the elderly. So patients who are 65, 75 and older. And that's why we need to have a very specific way of managing chronic kidney disease in the elderly that is the most common population. So this is just based on US data in patients with end-stage renal disease, so requiring dialysis. As you can see, from 2000 until 2020, there has been a steady rise in the amount of patients requiring dialysis. And when you adjust it by age, you see the blue and the green lines, those are above the age of 65. It is significantly more prevalent amongst the 65 plus age group than those in the less than 65 age group. So I'm gonna start off with a little case. This is a typical clinical case that I see almost every day in my clinic, and I'm sure as primary care doctors, you see this all the time too. So we have an 85-year-old male with the typical metabolic risk factors. So he has hypertension, diabetes, hyperlipidemia, and he comes to your clinic for management of chronic kidney disease. And, the patient, maybe not an 85-year-old, maybe someone younger, Googled that he has stage 3 chronic kidney disease and is very nervous about what this means and is asking you as the doctor, what is his risk of ending up on dialysis? And so my experience with chronic kidney disease is patients don't really understand the significance of chronic kidney disease. What their only thing that they care about is, am I or am I not going to end up on dialysis? So it's important that we know how to cancel our patients on their individual risk of developing end-stage renal disease. So how do you counsel this specific patient? So I already mentioned this in the first lecture, the first presentation about the chronic kidney disease stages. So we have stage 1 to 5 based on the eGFR, and then A1 to A3 based on the albuminuria. But if you tell a patient like this patient that they're CKD stage 3, that doesn't necessarily mean anything to the patient. If anything, they'll tell you stage 3 is close to 5, and they start panicking. So this really is useful to a certain degree, but it doesn't tell you or tell the patient about their specific individual risk of developing end-stage renal disease. So if there's one thing you take from this presentation, it is this, the kidney failure risk equation, which is really useful in predicting each patient's individual risk of developing end-stage renal disease. This was published in 2011. It has been validated in a large cohort of patients, and as nephrologists, we use this every day in our clinical practice. So basically, the kidney failure risk equation is a calculation where you plug in different variables of the patient's information, and it will spit out a number that tells you what is this patient's risk of developing end-stage renal disease. And it looks at these different factors. So it looks at their urine microalbumin, which throughout all the lectures today, we've talked about the importance of the urine microalbumin, looks at the patient's sex, male or female, looks at their age, and then looks at their GFR. And so this is what the kidney failure risk equation looks like. So you plug in the patient's age, their sex, their region. It's split into North America and not North America, their GFR, their urine albumin. You plug in the specific number and you pick the units. So going back to our patient. So we put in an age, he's 85, he's a male, he's in North America. And based on his labs, his GFR is 30. So remember, he's CKD stage 3. His GFR is 30. And fortunately for him, he has very minimal albuminuria. So he has 15 milligrams, for example, per gram of albuminuria. So when you plug this information in, it'll tell you, yes, the patient has stage 3 kidney disease. But what's really important here is that you look at their risk. So their 2-year risk of ending up on dialysis is 1.33%. Their 5-year risk of ending up on dialysis is 4%. So for an 85, when I tell my 85-year-olds that their risk of ending up on dialysis in 2 years is 1%, I tell them that there's a very good chance that their kidneys will outlive them. And so these are the patients that I tell them to not worry, to not stress, that provided that everything stays stable, they are very unlikely to end up on dialysis. Let's change things a little bit here. Just trying to really show you the importance of this calculation. So let's keep everything else the same. So same male, North America, same GFR, same albumin, and change the age. So instead of 85, let's make the patient now 25. What you'll see now is that the risk increased, right? It's still stage 3, but now the 2-year risk went from 1% to 5%, and the 5-year risk is around 15%. For a 25-year-old who still wants to live, hopefully until their 80s, this is more of a significant risk. Now let's keep 25-year-old, male, North America, GFR 30. I'm not changing the GFR in all these calculations. But now let's say they have uncontrolled diabetes and they have 5 grams, 5,000 milligrams of microalbumin in the urine. How does that change their risk? So again, they're still stage 3. Nothing has changed in the chronic kidney disease stages. But now their 2-year risk of ending up on dialysis is 50%, and their 5-year risk is 88%. For a 25-year-old, telling them that their 5-year risk is 88% to end up on dialysis, that is a significant risk. And so this calculation is very useful, I think, for clinicians because it helps guide our treatment. It helps guide primary care doctors on when to refer to nephrologists. It helps guide us in how to prepare patients for dialysis. But it also, I think, really puts into perspective for patients what their risk of ending up on dialysis is, which may be a motivating factor for them to, make their lifestyle modifications, to take their medications, to work hard on their diabetes and make all these changes that they need to make. So if there's one thing that you took from that lecture, I really hope you incorporate the kidney failure risk equation in your risk assessment for patients with chronic kidney disease. Now, there is a little caveat to this. So the GFR, the estimated glomerular filtration rate, is a calculated number. Remember, it is not based on a measured value. We measure things like creatinine, but the GFR is a calculation. And so what happens is you have certain disease states where your creatinine may be falsely low. For example, creatinine, which is based on muscle mass. So in elderly patients who are very frail, who have very low muscle mass, or sarcopenic, they may have a low creatinine, but it doesn't necessarily mean that their kidney function is better. It just means that they're making less creatinine, and so their GFR, their creatinine is going to be falsely low. And by the same vein, their urine albumin to creatinine ratio, because creatinine is in the denominator, it'll also give you a falsely low urine albumin creatinine ratio. So there have been talk about doing an alternative measure, something called cystatin C. So we said creatinine is released by muscle. Cystatin C is released by all nucleated cells in the body. So it is not affected by whether you have a lot of muscle mass or not, unlike the creatinine. So this is a study where they compared creatinine compared to cystatin C. And you can see, for example, and they looked at the outcomes, which was death from any cause in patients with a creatinine or cystatin C. And they noticed that, for example, GFR is 45. The patients had a different creatinine compared to a cystatin C. And those who had a cystatin C had a higher risk of death or all-cause mortality, indicating that maybe the cystatin C is a little bit more accurate than creatinine. I don't use this in all patients. I use this in patients who, again, have a low muscle mass. So patients who are very, very sarcopenic, or patients who have amputations and missing limbs, so they don't have all their limbs there, so they have less muscle mass. But something to think about in our elderly population. So going back to this patient, and so his 85-year-old, we sat with the patient. I usually do the calculation in front of them so they can see the numbers with their own eyes. Would you refer this patient to a nephrologist? If yes or no? And so who are the patients that you refer to nephrology, specifically when we're talking about chronic kidney disease? So typically it's patients who have chronic kidney disease stage 4 or 5 or a GFR of less than 30. Or they can have an earlier stage of CKD, but they have a rapid progression of their CKD. So in between every visit that you see them, their kidney function is declining. Patients who have significant albuminuria, so I would say less than half a gram per gram, especially if you don't have an explanation for this. So in some cases, if you know that this patient has diabetic nephropathy, they have an elevated A1C, they have retinopathy, gastroparesis, all the other things, you may be able to manage this on your own. But if they have worsening albuminuria or significant albuminuria, particularly if you don't know the cause, this is a reason to refer to a nephrologist. And then if you also have hematuria with proteinuria, so not urological in origin, this may be a sign of a glomerulonephritis, and you'll need to refer to a nephrologist for this. In terms of our patient, our 85-year-old who has very minimal albuminuria, who has stage 3 CKD, they do not, and very, very low risk of ending up on dialysis. This patient does not need to be seen by a nephrologist. And so as a primary care doctor, assuming this patient does not need to be seen by a nephrologist, how would you manage this patient? Or assuming that their risk is high, but because they're 85, because they have all these comorbidities, they tell you that I don't want to see a nephrologist because I never want to do dialysis. So how would you manage these patients in your clinic? And so this is where we talk about very specific considerations for CKD when it comes to patients that are in the elderly population. So this is just a very nice visual of the whole adult lifespan. And you can have CKD at any point of these age groups, but each age group has a very specific considerations that you need to take into mind. For example, in younger patients who have CKD, maybe you're thinking about things like transplant and being more proactive about treating their underlying diseases. In the older population, there's a whole other slew of other things that we need to think about. You have to think about their chronic medical conditions. You have to think about things like frailty, their cognitive functions, which we just had a presentation on earlier, polypharmacy, and end-of-life care. And so this is a nice graphic in the middle showing the chronic kidney disease and what it could lead to. So chronic kidney disease is very frequently associated with frailty. and functional disability. A lot of these patients also have polypharmacy. And in the blue boxes are some of the consequences of these diseases. So they can have falls, they can have a decrease in functional status, decrease in cognitive function. They can have worse outcomes such as death or decrease in quality of life. And then in the green boxes, you have some of the interventions that we can do to mitigate these things. So you can enroll these patients in exercise and rehabilitation programs. You can do risk assessments. You can do specific medication management programs, particularly if they have polypharmacy. So it really is a multidisciplinary approach that needs to address each aspect of their disease. So I don't have to tell you all that with more diseases comes more medicines. And I know that in our previous presentations, we were telling you all about the different medications you should start. And we listed at least 5 that any patient with diabetes needs to be on. So when these patients get older, polypharmacy becomes a huge burden on these patients. And not only does it become a burden in terms of its bothersome effect for the patients, but also you're more likely to get into problems with side effects. So patient safety hazard, this is one of the things that you have to really think about in elderly patients on medications. And as we talked about earlier, a lot of the medications, just like insulin, are cleared by the kidney. So if you have worsened kidney disease, you are at risk of not clearing these medications and developing more toxic side effects from them. So this is a list of some of the medications that need to be taken into consideration when patients have chronic kidney disease. So the first class is medications with very narrow therapeutic indexes. So for example, where you have to monitor levels. So things like warfarin, tacrolimus, lithium, digoxin. We don't prescribe these necessarily as much, but these are important because any change in kidney function can lead to toxic supratherapeutic levels. Medications like NSAIDs and morphine also can accumulate when you have chronic kidney disease. Contrasted agents for imaging, for example, and then a bunch of herbal medications as well that we need to be aware of. This is dosing recommendations for specific or commonly used drugs by CKD stage. Again, most typically in the early CKD stages, you don't need to make adjustments to medications. But as CKD progresses, you really need to be monitoring the kidney function and reviewing their medications at every visit. So for example, metformin is typically discontinued when the GFR drops below 30. We said SGLT2 inhibitors, we typically don't start unless their GFR is greater than 20. If they're on it and tolerating it, we can continue. And there are many, many lists online that you can find. Word of caution, a lot of medications that you need to be particularly aware of in the elderly are things that could be sedating. So medications like, especially that you use for pain, so gabapentin, baclofen, morphine, these are medications that can definitely have very potentially bad outcomes in elderly patients with poor kidney function if they don't, since they're not excreting these medications. So we talked a lot about frailty. So frailty, there has been a lot of studies on frailty and its relationship to chronic kidney disease. So frailty is really a very complex word. It's a multi-system syndrome that is characterized by many different things, including a decrease in physiological reserve. It predisposes an individual to adverse health outcomes in general, and this is particularly true in the case of chronic kidney disease. And it has an excellent predictive validity in quantifying your risk for morbidity and mortality. The range of frailty among patients with CKD and higher is a pretty wide range, but I would say 14 to 40%. And this number is even higher in patients on dialysis. And of a lot of our elderly patients with all these comorbidities, including chronic kidney disease, they can have a lot of symptom burden. And the symptoms can be very varied. So this is just a list of symptoms that were based on surveys on patients with chronic kidney disease. As you can see, myalgias, feeling washed out or drained, cramps, dry skin, shortness of breath, lack of appetite, nausea, so many different symptoms, and they could be not necessarily from one disease, but can just be all their diseases together. And the mortality rates amongst this older population really increases. So this is data based on patients on dialysis specifically. And you can see that within 1 year of starting dialysis over the age of 85, their mortality rate is 71%. And I do use these statistics when I talk and counsel my patients, particularly when they're in their 80s, about what life would look like on dialysis. And obviously, it is different from patient to patient. There are some relatively healthy 80-year-olds and some very sick 80-year-olds. But I say general statistics will tell you, starting dialysis over the age of 85, your mortality is 71%. And this is actually interesting. This is mortality compared to other diseases. So on the left, you have dialysis patients compared to general Medicare population. So this includes all populations that see a primary care doctor. Their mortality is much higher. And on the right panel, you see dialysis patients compared to cancer patients. Their mortality is higher and higher than patients who had recent cardiovascular infarction. So do not underestimate the mortality associated with chronic kidney disease. We're talking more advanced chronic kidney disease and patients on dialysis. So from a primary care standpoint, what do you do when you have an elderly patient with multiple comorbidities who has advanced chronic kidney disease and it's not within their goals to pursue dialysis? So really we do a conservative care approach where we're trying to focus on managing the patient's symptoms. So if they're beginning to have some volume overload, you give them diuretics. If they have anemia of chronic kidney disease, you treat the anemia. So you can give them things like making sure their iron stores are replete. If their iron is replete, you could consider erythropoietin. If they're having symptoms of nausea and vomiting, you can give them antiemetics. So really very focused on their symptoms. If they have abnormal labs and you're trying to really not get them on dialysis, so if they have hyperkalemia, you can do potassium binders. If they have acidosis, you can do sodium bicarbonate. Dietary modifications, you're trying to balance this with ensuring a good quality of life. So you can, if hyperkalemia is an issue, you could potentially advise low potassium. I prefer using things like a potassium binder because it's very hard to adjust to do dietary changes, especially in someone in their 80s who just wants to enjoy life. And then really planning ahead. So doing things like advanced care planning. So having discussions with the patient, with their family, making sure that they're plugged in with enough social support. And if things continue to progress despite all of this, and the patient is, still within their goals not to pursue dialysis, then getting palliative care involved is important. And really the goal at this point is to maximize comfort, minimize hospitalizations and unnecessary interventions, and to preserve patient dignity. And so we reached the end of our talk. The main take-home messages I hope you all gleaned from this presentation is that GFR is only a part of the picture. You can have 10 patients with CKD stage 3, and each individual patient would have a very different risk of ending up on dialysis. And that's why it's not enough to just look at the GFR. You have to do an individual risk assessment where you take the patient's age into consideration, their albuminuria into consideration, their gender into consideration, all through the kidney failure risk equation. The other thing that's also important is kidney function trend. So if a patient's GFR has been stable over 5 years, that is a much better prognosis than a patient whose kidney function continues to decline every time they see you in clinic. So all of this information will help give you a better idea of the individual patient's risk of developing more advanced kidney disease. In elderly patients, make sure you pay very close attention to medications that are renally cleared. With each patient, recommend doing a very comprehensive medication reconciliation and to review what medications are renally cleared or need to be dose adjusted. And then in the elderly patients who are not a dialysis candidate, whether because of their comorbidities or because of their personal preferences, really focusing on conservative management where you're focusing on their symptoms and their quality of life would be very important. And that is it.
Thank you so much. Again, another very practical presentation. Thank you for introducing us to the kidney failure risk equation and taking us through the different numbers so that we could see exactly how even the change in age or change in one of the factors can make such a great difference in a person's risk or for going on dialysis. So thank you very much for that. Also, the conservative care approach, often with our older patients who do not want any heroics, shall we say, do not want to go on to dialysis, do not want to do anything more. It is still our job to care for them and to make them, as you say, as comfortable as possible and minimize their hospitalizations. So we do thank you for that presentation. Now there are a few questions in the Q&A. I'm going to open it. Any Dr. Raslan, Dr. Womack, Dr. Safdar, I think you are all with us and you are all experts in the area. So I won't direct it to any one person. So whichever of you feels comfortable, though of course the earlier questions were from the first presentation and so on. So the first question I see here are, what are the guidelines for using a mineralocorticosteroid receptor antagonist in persons with A2 and A3 levels of proteinuria? I believe, Dr. Raslan, that was related to your first presentation. Do you want to make a comment on that?
Sure. So I think I mentioned it briefly, and Dr. Safdar mentioned this briefly. There's less data when it comes to the lower levels of proteinuria. Most of the trials did look at, more than 200 or 300 milligrams per gram. I would say if the patient, you've already maxed out on the ARB, you have them on all the other medications, the SGLT2, the GLP-1, you're doing strict glycemic care, and they're still having persistent proteinuria, even if it's low, and if they can tolerate a mineralocorticoid receptor antagonist, I would start it, provided they don't have problems with, because if you're doing both RAS and mineralocorticoid receptor, you can run into issues with hyperkalemia. If they're not having any issues with that, their blood pressure can tolerate it, then go for it.
Thank you. Next question, patients with chronic kidney disease who have normal blood pressure, if being asked, can we still start an ACE or ARB? I think that was covered, but if you want to just reinforce that.
Yeah, you start at a very low dose. Well, depends on normal, like if their blood pressure is 120 versus 90, If I'm starting off with an elderly patient with a blood pressure of 90, I may be more hesitant. But a lot of our younger patients who have blood pressures maybe in the 110, 120s, I still do start, but a very, very low dose, because even the low dose is going to have a benefit. And you start at a really low dose and you monitor the blood pressure and see if they can tolerate high doses.
What would you consider a low dose in this context?
I've even started lisinopril 2.5, which is a whiff of an ACE inhibitor.
Yes.
Or lisinopril 5, very low dose.
All right. And moving on, is there any place for the use of pitoxiflin in the prevention or treatment of CKD? You can also open the question and answers on your computer so you can see.
Yeah, to be honest, I had to look this up as kind of some of the other speakers were talking, and so I did see like that there was some data that perhaps that there could be some reduction in or like improvement in CKD, but right now it's not currently part of the guidelines. So I wouldn't say it's something routine that we're using this medication right now.
Okay, thanks for that. Next question. If a patient is on maximum ACE ARB but still has microalbuminemia, what's the next step?
Yeah, so I think that's going through the progression of all the medications that we want to add. So if someone is already on a max dose ACE or an ARB and they're still having proteinuria, then greater than 300, I know macro is kind of the old term that we used to use for like A3.
Right.
And so now we're kind of moving in terms of terminology and using A3. So then I would certainly add on that SGLT2 inhibitor, whether or not they have diabetes or not. So really, if you're greater than like 200 and you don't have diabetes, then you should absolutely start. If you have diabetes, you want to get that urine albumin down as much as you can. So I would be starting, the ACE or an ARB, then I would be starting that SGLT2 inhibitor. And then after that is when you're getting into the GLP-1s and MRAs.
Thanks for that. The next two questions are really asking about the app that was used to calculate the risk and how it can be assessed.
So I just put the link in the chat. You can just Google kidney failure risk equation and it'll be the first link. I showed you all the first page of, the age, the sex, the urine creatinine. If you plug that in, it will ask you to include more information such as albumin, phosphorus, bicarbonate. You can skip this step. I always skip this step. So you don't need all that information. It's they use it to do even more granular of a risk assessment, but you really don't need it. So you can skip that step and it'll immediately give you the information.
Thanks for that. Dr. Aguvaya, did you wanted to say something? I think I see
no,
a message here.
I put in the chat the links to some cardiovascular risk calculators. Because this is as some of the colleagues have already mentioned, this is a real direction that research and clinical practice are moving in for different disease areas, is to use the existing research and through the help of artificial intelligence and machine learning models to produce these risk calculators. So we have some for kidney function and risk for renal diseases. We have others related to dementia and brain health care. We have others that are really composites of non-communicable diseases and risk factors for those, as they might predict some other type of disease of interest. So this is a big area of research and clinical practice. And I would encourage, if you're interested in a specific disease, just as the other colleagues have said, start to do some Googling and put in the name of the disease and put in risk calculators, put in machine learning models, artificial intelligence, and you'll see that there are web-based apps as well as smartphone and other device-based apps as well.
Hey, thanks for that, Dr. Aguvaya. And I see another question here. Can you speak to the use of the 2021 CKD EPI method for eGFR calculation versus the 2009 race base for the Jamaican population? So I don't know if any of you would like to tackle that. A very specific question.
I'm not sure specifically about Jamaica. I think there was a lot of controversy in the last, couple of years about the race-based GFR calculation, not necessarily for people from Jamaica, but it's basically Black versus white, where many years ago, there were many underlying assumptions about Black patients that were incorrect and not based on data, suggesting that Black patients, had higher creatinines and therefore, this calculation put them at a disadvantage in that it overestimated their kidney function, which had downstream consequences in that they weren't getting referred for kidney transplantation as much as whites because they were thought to have better kidney function. So now we do not do race-based kidney calculations for EGFR. Most places in the United States have gotten rid of it. And I think it'll be the same it'll apply for, Jamaica versus other countries. We just don't look at the race anymore.
Can I say that what I think that we do look at, though, are the social determinants of health. And so you'll see that there are a number of risk calculators that are starting to ask the clinicians to input that data as much as they have that data available. And also using surveillance data that is collected from our public health systems to ensure that those models are also adapted.
All right, I don't know if there are any other questions from anyone else in the room. Those are all that were posted. And unless anyone else has anything to ask or to say, I think
I'm actually just going to share my screen because I think that race-based is actually really important. And I'm just like bringing this up from my notes. I know it's a little bit small, but hopefully you can see this. And so here you can see it's like 3 different patients. And this is when there was the race-based equation. You can see that all 3 of these patients, here we have a 22-year-old Black male, 58-year-old white male, and then a 80-year-old white woman, all with the same creatinine. But the GFR that it basically computes when you did incorporate race and sex, it was actually both race and sex. For this 22-year-old, it's computing a normal GFR, as opposed to these patients, it's, stage 2, stage 3. And so what was happening is that these patients, as Dr. Roslin were saying, were getting on transplant lists earlier and whatnot. But these have actually been removed. And even at Duke, this was a big movement in the last couple of years where we removed the race and sex. And so now we are using the new equation. And so, this is just even like more data down here and just showing like what the impact of that was. So I think that's a really, really important question. And then I did see one other question in the chat about CRP as well and inflammation. So if you guys can see my screen here, there is some data on that like, I didn't get into this, but this is part of the cardiovascular talk, and an inflammatory state is one thing that is thought to be associated in one of the non-traditional cardiovascular risk factors, specifically in CKD. There's only really been one study that has really looked at it, and it was basically an IL-1 inhibitor. And it did show that, in these patients, this was like a post-MI population. And those patients who were treated with an IL-1 actually did have improved cardiovascular outcomes. And this, they included actually patients with CKD and without CKD. And so this is like the CKD cohort, and you're seeing some benefits there. But then they did do the post hoc analysis and compared patients, with CKD and without CKD, and they actually were similar. So, I think it's a good question, and I, see like where it's coming from in terms of like practicality and where we are. I think this is honestly the only study that I know of that's showing any anti-inflammatory medications, and it's not something, again, in guidelines or in practice. But I think it is something just interesting to note. So.
Thanks very much for that. Okay, and I really want to thank all the presenters today, but I don't want to steal the thunder of the person who is designated to give the vote of thanks. And that is Dr. Dane Levy, who is the Honorary Secretary of the Caribbean College of Family Physicians Jamaica chapter. So I'm going to hand over now to Dr. Levy to do the formal vote of thanks. Dr. Levy.
Hi, Arlene. You could have stolen my thunder, and I would not have been feeling undone in any way. Good afternoon to everyone. The task is mine to say thanks to all those involved in this wonderful seminar, webinar, excellent presentations, all quite informative, quite comprehensive. And I must say, on a personally, I've learned a great amount of how to Hello?
Yes, we're hearing you. We're hearing you.
Okay, fine. All right. I think my internet would have taken a dip just a minute ago. Yeah, I was saying this is really a wonderful, wonderful, wonderful webinar. So informative on all aspects of it. And so without any further ado, let me just say thanks, of course, to our college, first of all, Caribbean College of Family Physicians Jamaican chapter, for putting on this wonderful webinar, the impact of non-communicable diseases on renal function. We had, for the first half of the program, Dr. Anna Brown Morgan was our moderator. So thanks to her, did an excellent job as usual. Dr. Arlene Henry Dawkins, who said a prayer. We thank her for that. And greetings and welcome by our president, Dr. Seni Ananuju, and I think the chief architect of this wonderful webinar. The first presenter was Dr. I'm hoping that I get his name correctly. Yes, Dr. Razlan. Yes. He did diabetes and chronic kidney diseases, strategies for early detection and management. And I might add that all of these presentations were geared towards preparing us as family physicians for screening and early detection of these changes, these challenges that can lead to onset of chronic kidney disease. Hypertension and cardiovascular, the renal syndrome, understanding the heart-kidney connection link. Our presenter on that topic was Dr. Kamal Safdar, consultant nephrologist. And again, an excellent job was done for that presentation. And on our second half of the webinar, Dr. Aileen Standen Golson, who is still sitting in the chair, she was our moderator for this second half of the program, in which we dealt with obesity, metabolic syndrome, and the role of lifestyle modification in preventing kidney disease. Our presenter being Dr. Caitlin Womack, an internist and nephrologist. Excellent presentation in that regard as well. And in between these last two presentations, we had Amaji Health, Dr. Ishtar Govia, and just want to commend you, Dr. Govia, on the work that you're doing in early detection of dementia, cognitive decline, how important that is in our society these days, getting more and more important. Our final presenter, which spoke on chronic kidney disease in the aging population, the challenges and management strategies, Dr. Razlan, consultant nephrologist, who of course also was, I think, did the first presentation. Another wonderful presentation, very informative, giving us guidelines and very, very helpful in equipping us to deal with the onset of chronic kidney disease, not just in the aging population, but in all aspects of non-communicable diseases. I want to thank our administrative staff and their team, Mrs. Lynn Thompson Hyatt, and of course, Sam of Oldgate Solutions, who gave us technical support and made sure that everything went pretty well from the technical angle. I just want to once again also thank those who were with us, all our participants, my colleagues. We still have 179 of you on the webinar presently. I think you all would have been saying and coming to the conclusion that you've spent a very profitable Sunday afternoon in the company of these wonderful presenters, and I think all except Dr. Aguvaya, all of these presenters would have been from Duke University in North Carolina. So thanking Duke and their internal medicine department as well for their support for the Caribbean College of Family Physicians. It would be amiss of me, of course, not to mention that video, the video that was presented, promoted, and I think presented and made by our Caribbean College. I think that is long overdue. I think it hits, gets right to the point of the importance of being a member of this college and all the benefits that it entails. I think that was a wonderful timing. And permit me in giving thanks once more to everyone who participated so well, so excellently, provided us with excellent information, which will only increase the effectiveness of our practice of medicine. I just wanted to put in a little plug, if I may, for World Family Doctor Day conference that's coming up on World Family Doctor Day, which is the 19th of May, 21 days away. And we are looking forward to that. And I'm hoping that all of you who have joined us on this webinar will find it possible to join us on that day as well. So once again, thanks to everyone. Thanks to Duke University. Thanks to all for all those excellent presentations. Thanks to Dr. Aguvaya. Thanks to our moderators. Thanks to our president, and thanks to all those who are involved in seeing to it that we had an informative, comprehensive, and very, very helpful webinar, which would increase the effectiveness of our practice and how much we can help our patients. Thanks again. Enjoy the rest of your Sunday afternoon to one and all. God bless you, and thanks again.
All right, thanks again, all. Have a good evening. Until next time.
Thank you very much.
Bye-bye.
Thank you.
And it's not raining anymore, so we're finishing up with our carnival. And we'll see carnival event right here. Thank you.
Thank you. Have a good evening.
Have a good evening.
Guardians of Caribbean Health, the vital role of family physicians. Across the sun-kissed islands of the Caribbean, family physicians stand as pillars of their communities. They are the trusted